Bore da, croeso i'r bwrdd iechyd Mark Hollindwy. This is the public meeting of the Health Board on the 10th of March. On behalf of the board, may I welcome you all to today's meeting, which is again being live streamed to enable members of the public to observe the meeting in real time. Members are also welcome to contribute in the language of their choice, as we have Anne with us today, the interpreter, to provide Welsh to English translation. Anne, can you explain to the board members the use of the interpretation for me, please? Okay, we'll skip that. We've done it enough as a board member to understand translation facility. So if there is a problem, please put it into the chat. In the meantime, I'll continue with the meeting. In terms of welcome and apologies for absence, I have apologies from Richard Micklewright, from Adrian Thomas. Claire Budden will be late joining, and I know Teresa's got to leave the meeting at some point and may not be with us yet because of other commitments. So the first item is the patient story. This is listed for Jill Harris. Matt, I know you are with us. Are you going to introduce this item, please?
Yes, Borodal, good morning. Thank you, Mr. Chairman. I will now play the patient story, which for this meeting is in fact a story from a carer, and it's the first time we've brought a story to the board from a carer, and that's in recognition of the work we're doing at the moment to engage with carers and their representatives across North Wales to develop our new carers plan, which will sit as part of our quality strategy. So if you'll just give me a short second, I will just now share my screen and start the story.
My 81-year-old mother lived on her own, and although she had dementia, she managed to live well. A paid carer attended every morning to prompt her to take her medication, and my sisters and I were around to support her. On the 7th of August 2021, a carer arrived and found my mother lying naked on the floor. We had no idea how long she'd been lying there, but we assumed it had been for some hours as she was cold. She was taken by ambulance to Ysbyty Gwynedd, and because of her dementia, my sister was allowed to travel with her. After some time, it was established that my mother had fractured her hip, and she was transferred to Ogwen ward. We were told it would take 12 weeks for the fracture to heal, but it wasn't explained to us why surgery was not an option. We wondered if it was because she'd had a bad reaction to general anaesthetic some years previously. We found it so difficult to get through to the ward. Whenever we tried to telephone the ward, the phones were either engaged or they would ring out and go unanswered. When we were able to get through, we were often asked to call back, as the person who answered the phone didn't know my mother, or because the person who was caring for her was not available. Because of the difficulties we were experiencing, one of my sisters resorted to emailing the ward manager on Ogwen a few times, as this was the only way of communicating. She also managed to contact the dementia specialist nurse, who went to see Mam and facilitated FaceTime calls for us. I am very grateful that my sisters and I were allowed to visit in turn. We found the environment on Dillas seemed to stimulate Mam much more than on Ogwen ward, and she looked more like herself. On the 1st of September, Mam was transferred to Morfa ward at Llandudno General Hospital. It was her birthday the following day, but none of the family could visit, so she spent the day alone. When we asked why one of us couldn't visit, we were told it was because of COVID. It wasn't made clear if there was an outbreak on the ward, and that was another cause of concern for us. On the 3rd of September, I received a telephone call from a doctor who told us to prepare for the worst, and a DNAR was put in place. We were informed only one of us was allowed to see her at this time, because she was so gravely ill. But of course, we all wanted the chance to say our goodbyes. We couldn't understand why she had deteriorated so quickly, and we were shocked and upset because we really didn't think she was at this stage. Janet was best placed to see her, and she later described Mam as looking like death. As a family, we feel she declined so rapidly because she would have felt abandoned by us due to the visiting restrictions. While she did have a mobile phone with her, no one handed it to her, as she would have required some help to use it. Before Mum was admitted to hospital, there were times when she would refuse to eat. In fact, she pretended she couldn't eat. But we realised it was something she was putting on, and we found ways of cajoling and tempting her to eat. She started doing this when she was at Ysbyty Gwynedd. And of course, because of staffing issues, there was nobody there to encourage her to eat. The ward did not contact us about this. They pressed ahead with arrangements to put her on fluids and arranged for one of us to go in to support her during meal times. We felt that putting Mum on fluids was not the right decision for her, and she lost 1.5 stone, and subsequently she forgot how to swallow. Having received such bad news about Mum on the 3rd of September, we were astounded when we were informed on the 6th of September that she was medically fit to be discharged home. However, they quickly changed their minds because social services needed to be involved to provide a care package, and they subsequently submitted a referral. On the 17th of September, we were told only one person only would now be allowed to visit the hospital, and we would have to choose which one of us it should be. Because she had 10 days annual leave available, Julie was chosen as the person to visit, and we fully expected Mum to be home at the end of this period. Mum was moved from Morfa to Aberconwy ward, and only Julie was allowed to visit. Mum had an appointment for a scan at Ysbyty Gwynedd. My sister was told she could meet her at the waiting room and attend the appointment with her, which would give them another opportunity to see each other. Prior to the appointment, they were sitting together in the waiting room, which was full of other patients. We can't understand why this was considered to be less of a COVID risk than us seeing Mum on the ward. During the appointment, it was evident that Mum had been bleeding. She had been allowed to leave Aberconwy ward without anybody checking if she was fully dressed, and it was discovered she wasn't wearing any underwear. Staff at St David's kindly provided a pair of mesh underwear for her. We strongly feel that there was absolutely no dignity in the way she was treated. When we later questioned the ward, they said they had not been aware that Mum had been bleeding. I went for 76 days without seeing my mother. My other sister went 78 days. I didn't see her until she was eventually discharged on the 18th of November. We were informed that it had taken so long for the discharge to take place because social services had not picked up the referral. Mum wasn't able to return to her own home and is now resident in a care home. She seems settled but is still very underweight. The SALT team are visiting and providing good support.
Thank you, colleagues, and that concludes Cheryl's carer story. We'd like to thank Cheryl for taking the time to share her story with us. The story has been shared with all of the services involved in the care of her mum, and those teams have reflected on that. The paper that accompanies this describes a range of improvements that are in place. It would be, I think, important for me to highlight that visiting restrictions have been a significant cause of poor patient experience and poor care experience over the preceding almost 2
Is it just me who's lost Matt?
No.
No, okay. All right, well, we'll carry on. Joe, did you want to come in first before I bring Cheryl in, please?
Yes, if I may, Chair. I'm sure Matt.
Now we've lost Joe.
Got to be probably the IT at Carlton Call. I'll give it a couple of minutes to see if Joe dials back in. Okay, I'll suggest we continue. If members want to highlight any questions or issues that they wish to raise in terms of the patient story, please do that now, and then we'll record those and seek a response from the executive team out with this meeting. So Cheryl, you raised your hand first.
Thank you very much, Chair, and apologies for not having my camera on, this poor connection in Old Colwyn as well. Well, first of all, I'd like to thank the family for doing this and to welcome a carer's story. Carers have been the backbone of our services throughout the pandemic, as they always are, but especially during the pandemic. And I'm sure I'm not alone in finding this a very distressing but also familiar story. My points are the inconsistency of our systems again regarding COVID and not clear messaging to families. Questions really, the process for prior agreement with staff regarding designated relative and carer visits. I'd like to know if this is a written protocol, whether it depends on the human factor, and how this is progressing. My next question is, how could supposedly experienced nursing staff have done care plans and managed this patient's care without close liaison with the family of a dementia sufferer? That seems that seems quite unacceptable. My next question, was the patient accompanied to YG, and what is the policy for transfer of vulnerable patients? Do we send a member of staff with them when they have dementia? And obviously the family highlighted the fact that this patient was sat in the middle of a room full of other people, many of who could have been suffering from COVID at the time, which seems bizarre. A question to Sue Green, if she's there, where we're up to with ward clerks to take calls and liaise, and how are we going with the recruitment drive? This is in general for this much needed improvement to the service. An observation, carers are vital. Yet again, their expertise and status is diminished and ignored. They could have passed on an absolute wealth of information about how to coax this lady to eat, amongst many other things. And my final point is, how will the patient and carer experience team seek assurance and evidence that these changes are now embedded? And where will it come through governance? I think that's my most important question. But thank you very much.
You're on mute.
A good set of questions, Cheryl. Thank you. Sue, there's one directed at you. Did you want to respond?
Yes, Chair. Apologies, just trying to get off mute. So the recruitment for the additional support for wards to answer phones and to take messages to release nursing staff is underway. We've been successful in recruiting to a number of areas across the health board. I will double check the exact details for the different sites, if that's okay, and provide that outside of the board.
Thank you very much, Sue. And I don't know, I can't see whether we have Matt back with us to ask about the seeking assurance and evidence and where it comes through governance. I'll wait for that response later. Thank you very much.
Thanks. I can't see Matt, but in any case, Cheryl, he may not have heard the questions. So the board clerk will record the questions and then convey them to Matt and the executive team. Then I would request that we receive a response within 7 days. John?
Thank you, Chair. Yeah, it's a distressing story quite clearly, but I wonder in terms of, there's no reference from the family or in terms of actions going forward around the use of the funded services from the third sector that as a board, we fund both dementia organisations and carers, both at GP level and at discharge points across all our general hospitals. In terms of the actions going forward and improvement, there's no reference at all to that provision. So I just wonder, as a board, what we're doing with our contracted services and why they were not brought in, because clearly the family needed some advocate support at some time to help them along the pathway. Thank you.
Okay, is there a response from that from the executive, or do you need to take that away and respond to John's question out with? Joe?
Thank you, Chair. Thank you, John. So yes, you're quite right. Our third sector colleagues provide vital partnership support for individuals and families. These conversations would normally take part as part of the care planning process and as part of the wider social work assessment. One of our challenges is making sure that our colleagues who work on the front line are as fully aware as they need to be of the range of services and opportunities available to support individual patients, families and carers. So I think one of our additional actions as a consequence of the very affecting patient story that we've heard here today, speaking to the importance of communication, compassion and basic nursing care will be to ensure that colleagues are fully aware of the range of support opportunities that are available to patients, families and their carers. Thank you.
So can I suggest that in terms of the patient stories that are now coming forward, it would be helpful not just to rely on the experienced team to seek evidence of change and somehow seeking to ensure that it's embedded in that fashion, but that we might want to, as a board, given that we are returning to quality and safety visits, follow up stories such as this by a visit by one member of the board or another, so that we can see for ourselves that the changes have occurred.
Yes, agreed. Thank you.
Okay, so we'll pick that up outside too. So you may have missed, Joe, there were earlier questions. So I suggest those questions are noted and responded to, perhaps within 7 days, if that's okay.
I think that's extremely appropriate. Thank you, Chair.
Thanks very much. Okay, are there any other questions? Lucy, your hand is up.
Yes, thank you, Chair. I think it would be helpful for the board to actually see how this triangulates with other pieces of work. So this particular story, for example, is about Llandudno. Quality, Safety and Experience Committee received a report on concerns, including the wards mentioned in this story at Llandudno General Hospital. As a result of that, there's a very comprehensive action plan that's been pulled together. What it would be helpful to understand is how the experience here of Cheryl's story actually relays back to the ongoing work, so that we can demonstrate that the improvement work going on for Llandudno is actually making a difference.
Okay. Anyone want to respond? Joe?
Yes, I think this really helpful conversation is is developing, is building on a slightly different approach to how we report back on the actions that consequently to a patient story. And I think reflecting in the report on any other issues that are relevant to particular services to provide that additional assurance, I think is and will be incredibly helpful. Thank you.
Lucy, is that sufficient response to your query?
Yes. I think what we've explored at QSE committee is when we bring the patient stories, because we've been receiving patient stories at that committee for some time now. And I've requested that we actually at year end, we go back through the stories that have been presented to the committee to get an update on the improvements and the actions so that we can actually see what difference they've made and what sharing then that is taken forward. So to be able to demonstrate that, I think is needed to be able to show how the improvements are actually being embedded.
Yeah, okay, I agree. I'm sure Joe does too. So we'll respond to the questions within 7 days. We'll add this particular service ward hospital to our visits. So we'll, one or more of us will carry out a visit to the site too. And then Lucy, can you pick up with Jill your wish to see an updated brief on the actions through QSE committee? Yeah.
Yes.
Morwenna, did you have an issue you wish to raise about this?
Ia, diolch Cadeirydd. Yr unig beth mae siwr swn i'n deud ydy mae yna gyfeiriad yn y stori gen yr Cheryl am gwasanaethau cymdeithasol. Dwi wedi cysylltu efo Matt eisoes i gael chydig bach fwy o wybodaeth jyst mwyn sicrhau bod ni'n gwneud unrhyw ddysgu sydd wedi codi o'r achos a mae'n o'n uwchreolwyr i mewn cysylltiad dwi'n deall efo'r ward. Ond mae yna hefyd un o'r gweithrediadau neu'r dysgu sydd wedi dod ono fo'n cyfeirio at y ffaith bellach mae'r staff nôl yn y swyddfa, felly ella bod y peth di gwella. Mae siwr unig beth i godi'r bwrdd ydy mae trefniadau gweithio gwasanaethau cymdeithasol wedi bod yn parhau yn gyson drwy cyfnod Covid, lle bynnag mae'r staff yn gweithio o. Felly dwi'n yn siŵr ydy hwnna yn cau unrhyw gylch mewn ffordd, achos mae'r gweithrediadau yn un o'r un peth ac oedden nhw cyn Covid. Felly dwi am fynd ar ôl hwnna, mi na i adrodd yn ôl i Matt ac hefyd i QSE os oes angen Lucy, jyst i gair cylch yna. Dwi'n meddwl, os dwi'n bod yn onast, ella bod o yn narratif da ni angen trafod efo y wardia, jyst i sicrhau bod nhw ddim yn camddeall lle mae bes staff gwasanaethau cymdeithasol a sut mae hynna yn cael ei weld. Ond fel arall nag oes, diolch Cadeirydd am ddod â fi fewn.
Diolch, Morwenna. So I'll leave you to follow up in the way that you've said and link in with Lucy as necessary. So thank you. Okay, I'm going to move us on. That was another impactful patient story, which we take note of, and we've agreed some actions. Clearly, we want to be seen to respond to concerns articulated in stories like this rapidly where we can, and we want the assurance that we need as a board in terms of actions being implemented. So we will follow that up, as I've said. So I will move us on to the next item in point 3, which is declarations of interest. Are there any declarations of interest that anybody wishes to make? No. Okay. We move on then to the draft minutes of the Health Board. There are 2 sets of minutes. The first of the meeting on the 20th of January this year. Are you happy with the accuracy of those minutes?
Yes.
Okay. Thank you. The next. No. Right. Go on then, Jackie.
So apologies, Mark. I've lost my hand ability to put up. I'm not listed as present on the minutes. However, I was present.
Okay, that will be amended. Thank you. Any other points of accuracy? Lynn?
Same for me too.
Okay, so that will be
the next set of minutes.
And the same for the following minutes. Okay. Becky, does the same apply for the following minutes for you too?
No, strangely.
Okay. Okay. Right. So are those minutes subject to those amendments agreed on the 20th of January? Yes?
Yes.
Yes.
Okay. So we then move on to the extraordinary health board minutes, and subject to the change for Lynn's attendance, are you happy with the accuracy of the minutes from the 15th of February?
Chair, it's Cheryl here. Just to point out for the extraordinary board minutes, both myself and Jill Harris were, though we're down as absent, we were representing the health board at the risk summit called by the minister at very short notice. So though we weren't there, we were on health board business, and very sorry to have missed that meeting. Thank you.
You were, and thanks for attending that summit. Okay, so I'm going to move us on then to in point, Pedward point in, which is the action table. And I will walk us through this page by page, because there are quite a few actions here to be noted, and some of them are ongoing. So if I start with the first, there is an update most recently which Molly has arranged, and it's about the performance indicators being routed through PTHIG and onto board in the manner described in the revised update. John, are you happy with that action as chair of PTHIG?
Yes, Mark. I've had an offline conversation with Molly just to go through the proposal, and I think there are some questions in terms of process, making sure we include the views of others to make sure that any rationale for inclusion or not inclusion of measures are clearly enunciated and people understand where we are. But it'll be make sure we have a collaborative process in terms of getting to an end point. But yeah, I'm happy with the process.
Thanks, John. So on that basis, I will close the action and leave it, John, to be routed by your committee to the board in the way described.
Okay.
Thank you. Next item, sat with Tracer, Welsh language standards. Tracer's not with us at the moment, I don't think. Lynn is here for her, but that is on the agenda for later. So we will close that item here and return to it on the agenda, if you're happy with that. The next was concerned with the operational plan monitoring report and progress. The update is the model from the new OPMR has been revised to include learning from best practice in the NHS, etc. Are members content to close that action? Lucy first, then Linda.
Thank you, Chair. I think we need to be clear on what the timescales are for this one. It's been going on for some time. I know we have had a meeting with Sue Hill about it, but this is an ongoing action, and the update talks about the work to develop the new report for 2022-23 continuing at pace, but exactly when are we going to look at, because what we've got again for board today, it doesn't pick up any of the outstanding concerns that we've been raising for some time now, which I appreciate it was not under Sue Hill when we raised them previously, but we just need to be clear on when this is going to be done.
I think that concern is reflected in the later paper as well. Sue Hill.
Yeah, thanks, Chair. So the current plan is that the revised OPMR report will be live from the first quarter of the next financial year. There's quite a lot of work going on with the ICT team and with the performance team to make sure that we are taking into account all the feedback from the various committees. So, you know, the plan is that that report will be live from the beginning of the new financial year. So it gives us plenty of time, because it's a quarterly report, to agree both the format and the content with the subcommittee chairs, because we won't be reporting in that format until the end of Q1, which will be July next year, but we will have agreed the format, I would expect, by the end of April. So everything is in train. We've got people working on the report. We just need to have that sort of read across with the committee chairs.
Sue, while you're there, the operational plan monitoring report and the performance report, of course, closely aligned. I know we come on to that later, but you just want to give an indication while we're on the subject of when that will be amended and finalised.
Yeah, of course, the QAP report is slightly different. So obviously we're working for the same deadline, which is the beginning of the new financial year. So that report will be live from May 2022 to report on the month one business.
Okay, thank you. You might want to stay on because I think Linda and John have got questions too. So Linda.
Diolch yn fawr iawn, Mr Cadeirydd. Oedd yn nghwestiwn i yn debyg iawn i Lucy yn yr ystyr, oeddwn ni ar deall bod yr adroddiad yn cychwyn ar y 1 Ebrill. Dwi'n pryderu braidd gyda ateb Sue ar y sail bod yna ddigon amser, oherwydd dwi'n cymryd bydd rhaid cytuno cyn y 1 Ebrill y ffordd fyddwn ni'n casglu data a ffordd fyddwn ni'n cyflwyno data mwyn bod yr adroddiad diwedd Gorffennaf yn dechrau o'r 1 Ebrill. Felly, sy'n ni'n hoffi gweld hwyrach cyfarfod yn cael ei drefnu cyn y 1 Ebrill i drafod fformat a'r data bydd yn cael ei gasglu'n gwahanol. Gai hefyd ategu bod pwyllgwr hefyd wedi bod yn rhan o'r trafodaethau a di hyn ddim yn cael ei adlewyrchu yn y cyfnodion ar hyn o bryd. Felly, falch iawn o glwad gan Sue bod yr holl gwaith ar y gweill, ond dal yn pryderu braidd bod yr amserlen sydd wedi cael ei awgrymu ddim yn ymateb hwyrach i'r angen i gytuno'r fformat erbyn y 1 Ebrill. Diolch.
So I think that's a very helpful and fair observation. So we don't want to run into the new financial year with the 2 reports that we're not content with. You are working hard on them. So can I ask that you make the necessary arrangement, Sue, for a meeting to take place before the 1st of April? Yeah.
Yeah, of course, Mark. I'll make that. I'll get that in the next 2 weeks.
Thank you. John.
Thanks, Mark. I think my question is somewhat been answered now from what Linda was raising. I had the same sort of note of concern, and notwithstanding that I understand that the IT teams are having to work out where they're going to get data from, I think it would be useful as a suggestion that we have at least maybe a mock-up of what it would look like and what content is proposed, so we can agree that. Otherwise, there's a potential that people are going off and trying to put mechanisms in place to gather data, and either they won't be necessary or they'll be misdirected. So I think a meeting would be really helpful, and just something to be able to, as a model of the report, I think would help that discussion to go forward.
Yeah, thank you, John. I'm very happy to do that. So I'll try and get that meeting arranged and a mock-up of the report so we can have that discussion in a constructive way with the 3 committee chairs.
Cheers. So, okay, I'll move us on in terms of the actions then. The next was in respect of the Finance Month 5 report. So, there is an update at the bottom referring to this moving forward to PFIG on the 24th of February.
Yeah, thank you, Chair. So, yeah, I had a very constructive conversation with our independent member, Richard Micklewright, about learning he could bring to the savings programme. We also had a very positive discussion before the PFIG meeting on the 24th of February about what we could do to accelerate the identification of savings and bring that to PFIG in March ahead of the board submission. So that is all moving ahead, and we are already planning the PFIG papers, which are due in about about a week's time. So I think we've agreed the format and the content, and we are working on that as I speak.
Thanks, Sue. John, are you content with that?
Yes, I think so.
Thank you. Thanks, Sue. So we'll move on to the next one. That was the review of meeting effectiveness that rested with Louise and myself. There is a review underway, and changes are under consideration, and that does involve the Good Governance Institute as well. Louise, do you want to comment further?
No, I think you said it really, Mark. I think we've had some good meetings through the committee effectiveness group as a result of the board development programme, and there is some potential now, which I'll be working with Molly on, around actually reinstating the committee business management group, which I think can take forward that work more longer term, because it is quite a long-term action around our overall quality of reports and the kind of committee and board flows. So that's the next stage of that, which isn't quite reflected on the action log.
Thank you. So we'll leave that open and report back on that, Louise. The next item was in respect to the patient story, refers to it going, Lucy, to March QSC on the 1st of March. Did it go, and are you content to close the action?
No, I'm afraid it didn't go. And so we need to keep that action open and pick it up in May.
Okay, I'll leave you then to pick that up.
Thank you.
Next was around the workforce business case. Review progress on this at the next committee effectiveness group, and that is due to be discussed at exec board development according to the note on the 15th of June. So Sue, Louise or Sue, are we bringing that at the end of June then? Is that the plan?
Mark, that action actually more pertains to, it was born out of a discussion as part of the workforce business case, but again, it was linked to our earlier action. They're pretty similar around the kind of quality of papers and the flow out of committees into board papers. So while some of that work again will feed into the next executive group within the board development programme, I was wondering whether or not you would be willing to consider a sort of merge of those two actions, because actually they're quite similar. The sort of title of it's a little bit misleading, but it's born out of where that discussion point arose.
Okay, if that works, yes, but Sue wants to comment, so I'll let her come in first. Sue.
Thanks, Chair. I just wanted to highlight, I think Louise has just alluded to it. It is the emergency department improvement plan. It's the gateway process rather than a workforce report. It does have an element of workforce in it, but it was largely around the improvement subject to the business case that was approved around the emergency department.
Okay, so you're happy to pick it up in the way that Louise has described, yes?
Yes.
So we'll link the two actions, Louise, and we'll close that one off. The next, I know Jill is unfortunately not here because she's contracted COVID, Joe, but the next action was for Jill, and I'm not sure that action update actually responds to the action, which was, could a further update could be provided to board members on the 4-hour stroke target once the key meeting has been scheduled. It refers to a meeting being held and another to follow, but as yet, I don't think we've seen any update.
Thank you, Mark. So we will, once we've had the second meeting, be in a position to provide the update. Accordingly, that action should remain as open. I'll follow up with Jill and her colleague Phil to see how far we are on with being able to provide that update on stroke services. Thank you.
Okay, so can you keep us in the loop then, Joe, on that, please? Okay, I do realise that John's prompting. I missed the vascular action. It's on the agenda. That was at 5. GGI Commission's taking forward the process learning review, which I know is underway, and we are due to draft report in early March. Notwithstanding, we're due to discuss that later. We will leave that action open until we see the product of that review. I think our colleagues happy with that.
Yes, thank you.
Okay, so we then come down to the next action at 10, which relates to the nature of the narrative in the operational planning report. I think we've already commented on this in truth. Is there anything you wanted to particularly pick up, Lucy? Are you happy that we seek to address it through the revised report?
I'm happy that we pick it up as part of the revised report.
So we'll close it here, but we are certainly not losing sight of it because we are agreed that this needs to be remedied once and for all. So we'll move on to the primary care update, which refers to the access survey being completed within the next 2 weeks. it suggested a further update at the end of March. Are colleagues happy to await an update at the end of March? Chris, did you want to comment? I can see your video's turned on.
Thank you, Chair. Despite best intentions, we haven't quite caught up the delay that Omicron brought in terms of this, and then it's collapsed into some annual leave commitments for key people. I have seen the draft report and can confirm it will be available in a couple of weeks.
Thanks, Chris. So we'll move on then in terms of the next action. We have a few here, don't we, still outstanding. So the next was around the action log. Actions on logs have been given some additional information. Are you happy to close that action log action at 12?
Yes.
Yeah, thank you. The next was concerned with Jill meeting with John C outside the meeting to clarify hospital escalation and de-escalation. I see, John, a meeting's been scheduled but has not been held yet. Are you happy for me to close and you to follow that up with Jill? John?
Yeah, Mark, it hasn't actually been scheduled yet, but I'm happy to close that and follow it up with Jill.
Okay, can you pursue then, John? Yeah.
Yeah, I will do. And I've got my hand up for the next one as well.
Okay, well, let's go to the next one then, which is the corporate risk register.
Forgive me, I didn't raise this as an accuracy point under the minutes because it didn't strike me as such there, but the action, I'm not sure, reflects the question that was raised at the time about that corporate risk. It wasn't so much timescale, but I think it might have been content. But notwithstanding that, I'm not sure the response either addresses the issue of timescale or addresses the underlying concerns that we've got with, or I've got with, corporate risks and the risks in the bath and the construction of bath. But I am conscious that I've had conversations recently with Louise and more latterly Molly in terms of the review process for the bath, and I've agreed with Molly a process to try and coordinate where we should be on the digital risks as well as part of that.
Okay, so if you pick up the bath point, John. Joe, in terms of digital, we know that Nick is leading. We know that a new director of digital has been appointed. When do we anticipate seeing some form of update report which tells us how the implementation of the strategy is now to be pursued? Joe, did you hear that question?
Yeah, sorry, it seems to take ages to get myself off mute and onto camera. I had a meeting with our incoming director of digital yesterday in advance of his starting on the 7th of April. We discussed a timescale for exactly this piece of work. I have suggested to him that he spend some time getting to know the organisation initially and looks to provide this update report within his first 8 weeks. Thank you.
Thank you. Can we ensure that John's engaged in that, please, Joe?
I would. John was part of the interview process. I'm sure Dylan will make contact with John and that engagement is indeed part of his induction process. Thank you.
Sorry to chip in, Mark. I've already had an initial conversation with Dylan prior to him starting, so he's already made contact. So I look forward to further contact once he's in place and he's got his feet on the table.
Okay, thank you. Thanks, John. So I'll move this on again. The next item was associated with the corporate risk register, and there appear to be a meeting, Suji, arranged with Richard and others on the 11th of April. Is that correct?
Yes, that's correct, John.
Okay, so I'll close that action off of here and leave that meeting to take place and report back if need be. We then come on to the winter resilience plan, and action update is provided. Richard's not here. The proposal is to close the action. Are our colleagues happy to close it at this point?
Yes.
Yeah.
Yes.
Thanks. Next was around the quality and performance report. Measures will be agreed following the meetings with the acute sites. I get that point. But Sue, we need to resolve these things around the quality and performance report, don't we? It says the end of March. We're expecting those information and that information and those measures then to be in the draft report. Are we not?
Yes, Chair, we are. But what I'll do is I will meet with Jill and just give an update to the board before the next board meeting on that action.
Okay. We then move on to finance, Sue, and the first describes an update being provided by May, by looks of it, a meeting having been arranged in March.
Yeah, thank you, Chair. This is just around the table in the report that basically shows our variance to plan. The reason why we have that table in the report is that is how we report to Welsh Government, because they obviously monitor the position on a variance basis rather than an absolute number. So I'm keeping it in that format for the rest of this financial year, just for consistency. And then John and I can meet before the beginning of next financial year's reporting, just to agree if there's a better way of doing it.
Okay, thank you. The next few actions are proposed to be closed. Are colleagues happy to propose those actions, to close those actions? And then I'll come to the last.
Yes.
Yes.
Thank you. So last one was concerned with vascular and the reports to the QSE committee listed for you, Nick. Can you or Lucy provide an update, please?
Thank you, Chair. I think this is due for May, and obviously guided by the request there about format and clarity about that reporting. So very happy to take that forward, and that'll be reflected in the May QSE paper.
Thanks, Nick. That's helpful. Thank you. So having had a walk through those actions, we'll move on to the next substantive items. The first was briefing notes of members. There are none for this meeting. The second was a report from me. So just by way of update, there was a meeting on Monday morning to discuss vascular services, which we'll come on to, and the report to the Minister, which I submitted on Monday. We then met with HIW on the same topic. That is Lucy and I and members of the executive team. Joe and I then this week appeared before Public Accounts Committee on Wednesday morning, and we are due to meet again later concerning vascular following the board meeting today, and then I have a meeting with the Minister tomorrow morning. The plan in terms of the next meeting of the board, which is the extraordinary meeting of the board on the 30th of March, is to principally receive the IMTP, the Intermediate Medium Term Plan, for approval by the board, but also a paper concerning proposals in respect of the regional treatment centres. I would anticipate, though, there are going to be further items for that extraordinary board meeting following today's discussion, which I'll pick up when we come to them. So that's my update at the moment. Joe, you've circulated yours, which is comprehensive as ever. Is there anything you particularly wanted to highlight from your update, Joe?
Thank you, Chair. Just a couple of points, if I may, just to draw the board's attention to the supplementary documents noting the development and signing off of the IMTP for both shared services and specialist commissioning, and to particularly draw the board's attention to the proposed integrated all Wales approach to international recruitment. Other than that, I'm very happy to take any questions. Thank you.
Thank you. Any other questions? John?
Yeah, thanks, Chair. Thanks, Joe, for that. Couple, if I may, in relation to appendices. The first one being the appendix around Charter for Families Bereaved or Harmed through Public Tragedy. I'm very conscious that a lot of the public if they're actually faced with situations like that, are actually looking for information at a very early stage. The proposal seems to implicate that it's responding to things like public inquiries and inquests. And we know full well from past experience that these can take sometimes many years for them to come to fruition. I just wonder, in terms of clarity, whether it is worth considering adding a line in there of some kind, which is around the here and now response and how, as a board, we would actually respond to that. So I can see you nodding on that one, Joe. So that was the one point. And then the other one is actually in Appendice 2, which is referring to the All Wales Support Service. One of the points in there, under their risk, the only item that they've actually got showing as red is, in fact, the Employment Services Directorate and Payroll. In view of the difficulties of recruitment across Wales, and particularly across North Wales, as they are actually rated red, is there an immediate impact in terms of our own recruitment processes as a consequence of the All Wales service not functioning fully at the moment?
Okay.
Thank you.
Thank you, John. If I may, through Chair, I'll start off and then ask Sue Green to talk about the processes of improvement we're working on with our colleagues in shared services, particularly focused on streamlining the recruitment process, which is identified as being of benefit to both us as their consumer and them in terms of a provider of a service, with the aim of reducing the time taken. This is an issue that all health boards share with shared services, in terms of wanting to work through ways that we can safely reduce some of the steps in our engagement and recruitment process. So through you, Chair, if I may ask Sue to come in with just a little more detail around that engagement, which I have to say shared services have responded to incredibly well. Thank you.
Thanks, Joe. Sue?
Thanks both. So the recruitment improvement review we've talked about at the board previously. We commissioned this in autumn of 2021. We are now in our fourth cycle of improvement using IHI improvement methodology. Shared services are a part of that improvement and have been working very closely with us to learn how we can streamline recruitment processes. As part of that, we've also been reviewing the elements of service that are provided by shared service and the elements of service that are provided in-house, with a view to bringing proposals forward around rescheduling some of that, and particularly bringing some of the services that are currently done in shared services in-house. We're working across the All Wales Workforce Directors as well, a peer group that I chair, to very much understand the impact of the significant increases in the volume of recruitment being undertaken both by the shared service and the various health boards. We're seeing reports over the last 12 months of a threefold increase in the volumes of recruitment activity that the shared service have been dealing with. This has had an impact on their performance, but also it's very clear as part of our recruitment process improvement review that there are significant waste in the processes we've all anticipated previously. So that is something that we're working very closely with shared service on, but also we will be bringing proposals forward as part of both the recruitment improvement review and the people and OD workforce operating model review. We will be bringing proposals forward to bring some of the services in-house.
Thanks, Sue. John, has that satisfied your questions?
Yeah, I think it's good to hear that there is some work, but it is particularly concerning that they are actually rating themselves as red. Obviously, listening to what Sue has said, and the potential of bringing some things in-house obviously gives us greater control, but equally we just need to be mindful of what the contract arrangements are with shared services and whether they're actually meeting the contract that everybody would be expecting. But good to hear that there is progress. Thanks.
Thanks, John. Okay, and before we leave the updates, there's some more formal matters I need to record. The first is to record Chair's actions since the Health Board meeting on the 20th of January 2022. The first was in terms of the purchase of Forge Road Surgery on the 24th of January. The second was for Flow Psychometry contract award for the 4th of February. Third was accommodation for the CAMS TI team, which was an extension of the lease contract stroke license at the Optics Centre, and that was on the 7th of March. The fourth was a lease of rooms for the neurodevelopment services in the West area in the Intech building, Park Menai, which is on the 7th of March 2022. I also want to announce the new chair of the Health Professionals Forum, which at its meeting on the 4th of March elected Jane Wild as the new chair, following the stepping down of Gareth Evans from the role. Jane has been the health science representative on the HBF since December 2018. During that time, she's representing the views of a broad range of healthcare science professions within the BCH-UB organisation. There is other information about Jane that I'll share out with her here, but I've agreed that whilst the formal process to allow Jane to take up the position will now commence, she can and will be invited to join the board as a chair-elect in the forthcoming board meetings and workshops. And finally, can I note that there have been a number of late circulation and publication of papers for this meeting, which is of concern in terms of the board being able to exercise its function by way of governance and assurance, but also limits the ability of the public to follow the business of the board and the actions that we are taking. And therefore, it is my intention to be very strict now about late publication of papers, and it will be a very rare exception whereby a paper is allowed to go forward when the publication timeline preceding Thursday of the board meeting has not been met. So please all be aware of that, because that will be a strict compliance of a legitimate expectation in terms of publication. So I will move us on again, then we're on that note, and I will come to the Targeted Intervention Improvement Framework. Jill Harris was due to speak to this. Joe, is it you now or someone else?
Thank you, Chair. I'm happy to present the paper on targeted intervention. The paper is an important reminder to us all that whilst the targeted intervention and maturity matrices approach is an important piece of governance, and the processes and independence associated with the assessment of scores prior to formal adoption of scores at the board is, of course, only part of the point of the targeted intervention process. And while this paper does make clear we have particular aspirations in mind for May for our targeted intervention scores, importantly, this paper seeks to demonstrate how the maturity matrices and targeted intervention process is starting to deliver benefit for, most importantly, our staff, and to generate benefit, our patients rather, and to generate benefits for our staff in increased joint working across multidisciplinary teams and across the organisation as a whole. I'm very happy to take any questions on this paper. Thank you.
I think John G has questions and Lucy. So Lucy's hand's up first. So Lucy.
Thank you, Chair. The paper describes a lot of really good things that are going on, good actions taken forward. What I'm not clear about, and this may be presentation, how does this actually relate to the progress against targeted intervention? So as a member of the public out in our population, for example, if you look at mental health, it's the so what question. What's described here in terms of how action is being taken under the targeted intervention framework, how is that translating to progress against improvement for those services? I'm also a little bit concerned about, for example, there's reference here to the adult mental health services relating to the number of referrals for assessments. The service has largely maintained its performance on or around the 80% target rate. And I'm not sure I'd agree with that interpretation when you then look at the quality performance report, particularly the reference to improvement in the last 3 months. It's just being clear, I think, really on what difference have these actions actually made. It's going back to the outcomes.
Lucy, thank you. Lucy, yes, of course, the point of the targeted intervention and maturity matrices is, of course, to provide a framework for us to improve our performance across the 4 domain areas, but particularly with regard, of course, to mental health. It's a domain area that pertains to patient care, patient experience and patient outcomes. You're quite right. The processes that we put in place in order to independently assess the evidence as the maturity as the time frame develops across the maturity matrix year, we should start to become more able to understand that the interventions are or aren't making a difference to individuals' patients' experience. Inevitably, as we started the process of maturity matrices and improvement plans, our assessment of progress as we started to roll out changes in clinical practice initially has been a little more on the process side of things. As we move into these additional services and new ways of working, becoming embedded practice over time, our assurance mechanisms around impact will need to increasingly become focused on PROMs, PREMs or other indicators, evidence-based indicators of patient outcomes. So I think the challenge is right and appropriate. The purposes of targeted intervention is, of course, to secure improvement. I think over time we'll start to see those aspects playing in to the maturity matrix. I take your point with regard to triangulation and making sure that the reporting we're doing with regard to our maturity matrices also do consider reports taken through other aspects of our governance review. As you know, the processes behind the assessment of evidence associated with the maturity matrices have a degree of independence, both independence within the health board insofar as one of the executive directors who is not a lead for any of the maturity matrices leads the process of independent review of evidence. And of course, through our arrangements with the Good Governance Institute, we're also able to ensure a degree of objectivity associated with our evidence gathering. We're due to review again in May, and I'll ensure that your comments, Lucy, are followed up as we go into that next assurance process. Thank you.
Lucy, on the back of the conversation that we as a group of independent members had on Tuesday, I did have a conversation with Joe about it's not just your concern, is it? The wider concern about this cannot be about process, and we complete a process and then get to the end of it and there's no sign of improvement. the clue is in the title, isn't it? And I think Joe's just responded to that point, but we will need to keep it under our oversight as we move forward.
Yes, thank you, Chair.
Okay, John, did you have some questions?
Yep, thanks very much. Thanks, Joe. One of mine is in particular around partly what Lucy was referring to and the increase in numbers. Are we talking about an increase now which is actually coming to the same levels pre-COVID, or are we actually talking about an increase in excess of the pre-COVID level? And in which case, if it is a significant increase, do we actually have sufficient capacity within the system currently to deal with that level of increase, particularly in terms of any bed requirements where we might end up having to have patients who've got mental health issues being put onto general wards rather than within mental health services? And the second point is particularly around the link with primary care. Do we have any data at the moment with regard to the number of patients which are presenting with mental health related issues being dealt with at a GP level at the moment, almost as a holding area, and we could actually see a significant influx coming forward in the next few months? Thanks for that. Thank you.
Thank you, John. I don't have that data to hand, but what I can say is that when there are occasions where all of our inpatient beds are occupied, our approach would be to seek support from our neighbouring trusts in the English system who provide specialist mental health beds, as opposed to seeking to cite patients within our general medical beds. On occasions, we have felt to be very close to capacity, and we have well established plans in place to both support our neighbouring English trusts if they need to send patients to us, and of course they do, or the other way around. We're also in some circumstances a specialist provider for our neighbour in the South Powys healthcare, and so we do also provide support for that health board in some of our more specialist areas of service provision. Through you, Chair, I will respond to the data questions that John has raised that I don't have to hand right now.
Thanks, Jay. Cheryl.
Thanks very much, Chair. Just to highlight actually some of the mechanisms we're putting in place to drive improvements in terms of the CAMS services. We're developing a children's charter across North Wales so that the young people are engaged with the planning, development and the evaluation of CAMS services. And also we've had the launch of the Young Persons Safe Space project to support young people 13 to 18 with their urgent mental health and emotional well-being needs. And of course, we're having the improved links between adult mental health and CAMS with joint monthly meetings, which is aiding transition. Just to highlight those points. Thank you.
Thanks, Cheryl. Linda.
Diolch yn fawr iawn, Cadeirydd. Hwyrach bod hwn yn pwynt technegol, ond wrth bod y bwrdd bore yma yn mynd i cymeradwyo neu ddim yr cylch gorchwil ar gyfer y grŵp. Dwi'n cytuno efo y sylwadau sydd wedi cael ei roi gan y bwrdd bore yma ynglyn â symud o broses rwan i gweithrediadau a gobeithio i casgliadau. Ydy o'n bosib felly i ni edrych unwaith eto ar rôl yr aelodau'r bwrdd sydd wedi cael dyletswydda i cydgysylltu gyda'r grŵp lliwio. Ar hyn o bryd, mae'r cylchorchwil yn sôn bod yr aelodau hyn, a dwi'n un ohonyn nhw, yn cael gofyn mynd i'r grŵp lliwio os da ni'n dymuno. Fel da ni'n symud ymlaen, mae yna is-grwpiau eraill, wrth gwrs, wedi cael eu sefydlu yn ymwneud ag allbwn a casgliadau. Ydy'n bosib hwyrach i ystyried dros roi chydig bach mwy o rôl i'r aelodau hyn o'r bwrdd, mwyn bod na well dealltwriaeth wrach ac hefyd ar ran rôl i deall yn well sut mae cynnydd yn cael ei cyfnodi. Ga i edrych os mae y geirfa enwedig yn 5.1.1 yn cael ei ail-edrych am hwyrach? Dwi'n meddwl bod hyn yn rhwystro unrhyw cymeradwyaeth, ond ar hyn o bryd dwi'n teimlo bod y rôl aelodau annibynnol o'r bwrdd sydd yn cysylltiedig a sydd gobeithio yn cefnogi yr gwaith pwysig yma, ddim yn cael ei lleisio mewn modd lle dwi'n teimlo bod yna rhyw rôl gweithredol, actif gweithredol yn yr ystyr cydlynu yn ymwneud yr gwaith yn symud yn ei mlaen, dim gweithredol yn yr ystyr o ymyrryd, wrth gwrs. Ond ar hyn o bryd, dwi jyst yn gweld bod y geirfa sydd wedi cael y geiriau sydd wedi cael ei ddewis ddim yn rhoi neu ddim yn sôn mewn modd lle dwi'n gweld yn derbyniol ar gyfer y rôl sydd wedi cael ei benodi ar gyfer ni fel aelodau annibynnol. Diolch.
I suspect, based on the conversation on Tuesday at our meeting, your view is supported by others. Linda, can I invite you to suggest an alternative wording that Joe and I will then consider together and report back? I wonder, Joe, too, in any case, May will soon be upon us, and I wonder if there's a need in any case for the executive leads and the link IMs to come together as a group to check in as a group to ensure that we are on the same page as we move towards May.
Yes, very happy on both of those suggestions. Thank you.
A dwi'n hapus iawn i cydlynu ynglyn â gwelliant. Diolch yn fawr iawn.
Diolch, Linda. Okay, so we will arrange that meeting, and if you let us have alternative wording, Linda, that would be helpful. Thank you. So we are asked to note the progress in delivering targeted improvement, and also to approve the targeted improvement steering group terms of reference, subject to what will be that amendment. Are you happy to do so?
Yes.
Thank you. Thanks, Lynn. Okay, I'm going to move us on again then to the COVID-19 update. Joe, I know you're doing a lot of speaking in the absence of some members of your team. Can I suggest that we accept that the report and the presentation have been read, because they have been circulated, and that you focus on, or your team focus on, anything you particularly want to highlight, and then I turn us to questions.
Thank you. So taking the report and as read, a couple of things to draw the board's attention to. Noting, of course, the changes to the management of COVID test and trace, as outlined with Welsh Government. Just to say that through Teresa Owen, Executive Director of Public Health, we're now starting to develop our systems and processes for moving away from the TTP model of provision in line with Welsh Government requirements. We will obviously do that work in partnership with our local authorities who have been with us lockstep of the way during the COVID process with regard to TTP. The situation with regard to vaccination is very interesting. So we're currently well on track to start the process of vaccination for our younger cohort, and are planning the implementation of the booster programme for those cohorts identified most at risk. We will proceed with the vaccination programme to offer appointments using our Office 365 approach. We're the only health board in Wales to use that approach, and that will enable us to start the process slightly ahead of Digital Health Wales support platforms, which are being developed in parallel. But we feel we can make that change safely, and Welsh Government have encouraged us to take that approach. We're keen to do so, and not only because that enables us to make sure that we have sufficient time and capacity to work through issues particularly associated with the housebound individuals, but also because we're keen to continue our successful programme of avoiding vaccination wastage. Whilst we talk about COVID regulations changing, it's important just to note that community incidence does move up and down, and we do typically at any one point in time have around 80 COVID positive or recovering patients as inpatients across the Betsy Cadwallader footprint. The other just piece of information that's relevant for board is to understand that COVID-19 remains quite a volatile area of healthcare provision and policy development. Yesterday, we were encouraged in one of our meetings with Welsh Government to take a stronger view at some of our IPC controls that we have in place in order to see if we could consider where safe and appropriate to do so, to reduce some of the social distancing, which we will consider carefully and appropriately, being mindful of the obligations we have to vulnerable patients and to our staff. But clearly there's a dilemma for us with regard to social distancing within our facilities and our ability to move into planned care recovery at the pace all of us would seek to see being put in place. Very happy to answer any further questions colleagues might have. Thank you.
Thanks, Jay. John G, can I come to you first, please?
No question on this one, Mark.
Can you have a point about accuracy, John?
In relation to the in relation to the numbers, was it?
I think you queried a date in the situation report of the 4th of March.
Oh, sorry, it was just, yeah, purely a typo element on that.
Okay.
Dated for the 4th, sorry.
No problem. Any other questions or observations from colleagues? No. Okay, thank you, Joe. We will move on then, and that update is noted in terms of the report and the presentation, and we are asked to endorse the decisions made by the Gold Command Resilience Meeting. Are we happy to do that as a board?
Yes.
Thank you.
Yes.
We'll then move on to in point now, which is items for consent. There is one that concerns Mental Health Act, and the board is asked to note the report and ratify the approvals in line with the Welsh Government guidance as listed. Are you happy with that recommendation and to support it?
Yes.
Yes.
Thank you. Thanks very much. So we now move on to the second section of the meeting, which is strategic items for the future. The first is a update in terms of the integrated medium-term plan from Chris and Sue. And you've already heard me say it's listed for our extraordinary meeting on the 30th of March. But Chris, to you.
Thank you, Chair. So I just want to provide a short update on the work for the integrated medium-term plan. As you've just heard, this is due to come to the meeting on the 30th of March. Work on the plan continues to progress, and board members will be aware that we have indicated our intention to submit a balanced IMTP for consideration later this month, and then through to Welsh Government. That work is progressing, but it is challenging. We've indicated in the last couple of weeks to Welsh Government that there are a number of risks that we will need to manage within the submission. Those risks are similar to other health boards. There are risks in our financial balance that relate to the ongoing COVID-19 pandemic. None of us know yet what the coming year is going to bring in terms of COVID, and we will need to bear that in mind. There are risks in our financial balance related to a number of extraordinary cost pressures. Examples of those include energy costs, national insurance increases, and of course now as we watch the activity that is occurring in the Ukraine, we're beginning to see concern of further energy cost increases and a number of other supply chain concerns that will only add to our extraordinary cost pressures. And then the other area that we have signalled a particular challenge is in terms of our plan to recover planned care backlogs. And again, the health boards are experiencing similar difficulties. Board members will have seen earlier drafts of the IMTP and will know that this is now evolving into what is a substantial plan. And a plan which is very tightly aligned to delivering tangible outcomes. I think that's positive progress, but we want to get it right. A lot of work is currently underway to finalise the planned care recovery plan part in particular, noting, of course, that planning is a continuous process, and so the submission only reflects a particular point in time. But we know that there are a number of areas where we can improve the current recovery plan. And so what we want to do is put forward the most considered and complete version that's possible. Joe's just referred to the conversation that we had with Welsh Government colleagues yesterday, and that will further change the submission that we put in front of you in a couple of weeks' time. That's the last part of the IMTP that we're really focused upon at the moment. And I think brings to a conclusion the update I wanted to provide, and look forward to being able to put in front of you a complete plan in what is little more than 2 weeks' time.
Thanks, Chris. Linda.
Dwi'n gwerthfawrogi yr diweddariad ac dwi'n edrych ymlaen gweld yr cynllun yn ei cyfanrwydd, ac mae rhai cyfadda yn y cyfarfod pwyllgor PPPH diwethaf roedd pethau wedi symud ymlaen dipyn. Dim ond i ategu, Chris, dwi'n gwerthfawrogi yr cydweithrediad gyda Sally Baxter ynglyn â i ni rhoi fewn yn y cynllun cyfeiriadau at sut fydd y Bwrdd Iechyd yn yr uchelgais y Bwrdd Iechyd i gwella mynediad i gwasanaethau yn iaith dywysol, yn enwedig i ychwanegu mynediad at gwasanaethau yn y Gymraeg. Ac gai jyst deud, fel bancampwr yr iaith, bo fi yn werthfawrogi y gwrandawiad dwi wedi derbyn gan Chris a'i tîm, lle gobeithio da ni wrthi rwan yn cryfhau y negeseuon hynny. Diolch.
Thanks, Linda. Chris, then, in terms of timeline, we would normally publish 7 days before the first year for the board meeting, i.e. the 23rd. Whatever you and Sue can do to assist that document being circulated to board members before publication, I think would be appreciated, specifically given the importance of the document. So if there is any latitude you can give us by way of earlier circulation, can you please do so?
Yes, certainly. We fully recognise the need to publish 7 days before. At the moment, the tightest point of turnaround on that is going to be in terms of translation. We can certainly share a pre-translated version for board members to start to digest the content before that, whilst whilst we're waiting for full translation. So I will happily commit to that. Yeah.
Thank you. Okay, that's the plan then. So I will take us off of that item and then on to the people and organisational development strategy. So in keeping with what I said earlier on, certainly I would like more time to consider the strategy given its importance. I understand the reasons why, but it was published and circulated late. So I suggest that we open the discussion here. We afford people the opportunity to make any comment at this point, but then we extend the opportunity for comment with a view to it coming back to board in the first year.
Okay, thanks, Mark. So I think if I can just say a few words and then open up to comments. Colleagues on the board will remember that we have stated the intent of bringing the people strategy together with the IMTP. After all, we will only deliver our IMTP through our people, and we've been very, very clear of the need to have an integrated plan. So the original intent was to bring the two together. So there do remain gaps within the people strategy and particularly the plan that can't be concluded until the IMTP is concluded. So my suggestion would be that when we circulate the IMTP, as we've just discussed, we also circulate the updated people strategy and the final plan together with that, because then that meets our commitment to delivering an integrated plan. I suppose just a couple of things that I would highlight on the strategy itself. It is the second people strategy for the health board, our first ever being 2019 to 2022. It is built upon the route map, so the Stronger Together route map that we had committed to as a board. It is also aligned to national strategies in relation to both directly employed, so the Health Education Improvement Wales, delivering a healthier Wales workforce strategy, but also the strategies for improvements in primary care, strategic primary care programme, and improvements in mental health and learning disabilities, as well as our progression towards really improving the population of Wales. So it is aligned to those national strategies, a number of which I'm directly involved in at a national level. So particularly developing our national workforce plan to deliver planned care recovery, national workforce plan to deliver improved strategic primary care. So I think just to call those things out, they are described in the document, but I just wanted to draw those out particularly. It is also importantly designed to enable the delivery of the improvement required through the IMTP. It is, as a strategy should be, relatively high level. There are very clear delivery plans underneath and a delivery architecture underneath. My suggestion aligned to Mark's was, given that it is so important, but also given that it should be seen together with the IMTP, is that we take comments and bring the two documents back together. Recognising that our people not only deliver the plan, but they are also a significant element of the cost of delivering the plan. Happy to answer any questions.
Thanks, Sue. Linda.
Diolch yn fawr iawn. So, a dwi'n meddwl bod yn bwysig bod ni fel bwrdd yn cymeradwyo'r holl gwaith sydd wedi cael ei rhoi fewn i'r datblygu strategaeth a'r cynllun. Ond gai gynnig bod hyn ddim yn dogfen gorffenedig. Mae yna sawl gwell hynny, ac gai ofyn yn garedig os fysa y tîm yn gallu dod yn ôl gyda dogfen sydd yn gorffenedig achos dwi'n meddwl bydd gennym ni mwy o hyder mewn cynnwys os mae'r dogfen ei hun. Mae gen i sylwadau ynglyn â peth o'r cynnwys, oherwydd dwi'n cytuno'n llwyr bod angen i ni addasu, bod angen i ni symlygeiddio, ac mae yna rhai rhannau dwi'n meddwl o'r strategaeth lle di hwnna hwyrach ddim yn glir os da chi yn ceisio rhoi eich pwyntiau drosodd. A dwi'n cytuno'n llwyr gyda'r cadeirydd, oherwydd da chi sôn yn y strategaeth bod hi'n strategaeth y cynllun, heb gweld y cynllun, nid yw yn bosib bore yma i ni cymeradwyo'r dogfen fel ac y mae hi. So dwi yn croesawu yr amser ychwanegol i ni ystyried, a bydda i yn hapus iawn i roi sylwadau mwy manwl wedyn. Ond wrth deud hynny, dwi yn croesawu'n fawr iawn y ffaith bod yr uchelgais yna i ni cydweithio gyda'n cynllun ni, a bod y strategaeth bobl wedyn yn mynd i fod yn cynsad gadarn i ni i symud ymlaen. Diolch.
Thanks, Linda. Can I make a suggestion that you, as chair of PPPH, and Sue join up outside? I know it was discussed at the committee. I know some concerns were represented by the committee members. So it might be an idea, I think, if you two were to come together outside the meeting, and that we seek to gain some assurance from the pair of you before we see the plan back alongside the strategy.
Hapus iawn i wneud hynny. Yeah, very happy to do that, Mark. Okay.
Thank you. Sue, you happy with that?
Yeah, Mark. Yes, that's fine.
Okay. Thanks. Claire.
Diolch, Mark. Sorry, I couldn't get my sound on. I apologise, I can't get the translations work, so I hope I'm not repeating what Linda just said, so apologies in advance if I am. When I was looking at the success measures on page 6 of the strategy, I guess, and I love kind of quantitative and evaluative performance measures that kind of get to the heart of what people feel about working for the organisation and their career development, etc. But I also felt in looking at that I was a bit unclear in the strategy what some of the quantitative measures of success might be. So how much are we expecting staff turnover to reduce by, staff attendance to improve by, staff satisfaction? So I'm unsure, because I'm not on any of the committees, whether some of that level of detail is being discussed and has been discussed and is being set at a committee level. But I think in approving the strategy, I'd just like to see a little bit more of what some of the quantitative and qualitative measures of success might look like. Thank you.
Thanks, Claire. So they are exactly the elements that are in the plan that we have. So we work through the plan aligned to the IMTP. It also goes into the minimum data set that's submitted with the IMTP. So a number of those measures are actually in the plan. So what I'm minded to do is to draw some of those through into the strategy as much as possible without repeating too much across the strategy and plan. But thank you for those comments, they're helpful.
Diolch.
Thanks, Claire. Nicola.
Thanks, Mark. So on page 9 of the plan, you talk about the national context. And one really important element of the national context is the prevention agenda. This document is about developing our workforce and supporting our workforce. And I can't see in this the element of prevention pulled through. Obviously, we don't have the plan, so it might be detailed within the plan. So that's one observation that I think we need to strengthen. Then the second part is around the executive group at the top of the pyramid at the end. And it's an observation and a thought. I'm wondering whether we need some sort of externality, a critical friend or something like that that's involved in our process. Because often when you've got just internal people working on things, it's like an echo chamber. And so it was just an observation about where that externality needs to be pulled in. Thank you, Mark.
Sue, did you want to respond?
Helpful pointers. Thank you. We'll build that in.
Thanks, Nikki. Okay, I have no further hands raised. So let me just say on behalf of the board, look, we appreciate all of the work that will have gone into this document and the accompanying appendices. and it's really important, and it's good to see the progress that's being made, clearly articulating where our priorities lie in terms of the workforce moving forward. I think it was always going to be difficult to handle this document here because, you know, it came late and it's an important document. So I want to just acknowledge the work that you and the team will have done in this regard. It will be helpful, as you say, to see the plan and strategy alongside the IMTP next time around. If there are any further comments outside, then they will be shared with you. I'll probably hold my own comments until I've seen all documents together, because I think that is more straightforward.
Okay, thanks, Mark. Thank you.
Okay. So we've noted the documents you presented, and that's the manner in which we'll deal with it moving forward. Thanks, Sue. So we come on to the operating model. So is it with you first? Yes. Okay.
Gosh. First thing I would say is, again, recognise there's a lot of documentation, much of which has been seen by board colleagues previously in informal and formal settings, particularly at the board last time. But I do recognise that it is a pretty significant decision to be made. I'm not going to go into and rehearse the reason that we're changing the operating model or the detail within the main document, as colleagues have seen that before and discussed it at length previously. I recognise and have picked up at the minute it was published the other day that there remain some inaccuracies, so we have fixed those for the document that would then be published into the organisation, particularly around job titles and a couple of errors. And hopefully colleagues will recognise that there is a lot of documentation, so we do get a little bit word blind as we kind of go through updating and making sure things are consistent across. So the material additions today, particularly for consideration, are pretty much the operational governance and assurance framework and the final equality impact assessment and socioeconomic impact assessment. If I could just briefly draw out a couple of elements of both of those documents and then open it up to discussion and questions. The governance and assurance framework, first and foremost, doesn't seek to change the governance arrangements that were agreed by the board last year and have subsequently been discussed at board level, board and executive level, particularly in terms of the feed through to board committees and assurance groups. So this document doesn't seek to change that. What it does seek to do is to better connect that infrastructure with the organisational governance and assurance structure, and very much to strengthen the golden thread that runs from our board through to individual delivery. Often described as board to ward, but in this organisation, ward isn't necessarily an appropriate recognition. I'm also a little bit mindful of using floor. I much prefer individual delivery, but recognise other colleagues will use different terminology. It also strengthens, or it aims to strengthen, the alignment to delivery of the organisational priorities and plans. We often have talked about as a board the fact that people across the organisation are working very hard, but we're not necessarily moving forward on those priorities that have been set by the board, or not moving forward at the pace required or at the quality required. What this governance and assurance infrastructure intends to do is to strengthen that alignment. And we've talked a lot as a result of the discovery from Stronger Together and in virtually all of our conversations about the need to align all of our people to delivery of our plans. It also serves to clarify and to simplify and to use a phrase we use quite often, unify the work undertaken across the organisation, and particularly making sure that we've got a more integrated model. Moving on to the EQIA, we have had the document here before, but there were some really, really helpful comments from board colleagues when it was reviewed last month. We've taken a slightly different approach, supported by our equality and inclusion subject matter experts, to create an equality impact assessment that is twofold. One, it looks internally at the impact on the people who are going to be changing within the organisation, but also externally in terms of the impact that the new operating model should have, is intended to have, in terms of the delivery of our purpose. to our communities. I've had some really helpful comments and feedback in advance of the board, and they've been really, really helpful. A couple of the errors we had picked up, as we said earlier. Hopefully I've covered a couple of the points, particularly in terms of how this interacts with the board structure, and the intent of the proposals in the governance structure. Again, recognise there is a lot of documentation there. These are some big decisions, so more than happy to take any comments and any suggestions about the way forward. Thank you.
Thanks, Sue. Medwin.
Thanks, Chair. Dear Chair. Thanks, Sue. Very comprehensive paper. I've not seen this paper before, so I'm not sure if it's been to any other meeting that I've missed, but this is the first time I've seen it and discussed it in committee, as it were. I just want to go through the risks, if I may, on page 30. You said into your introduction to the previous paper that delivery of the IMTP is through our people. And my main concern here is the people who we may lose, or that this change will have an effect on, that actually has an effect on our performance moving forward. Risk one, for example, we're developing the management arrangements without having completed the work on behaviours, for example. How does that tally with the mitigation that's going on, and how is that aligned with that work is underway, which it says under mitigation, to align developments in these areas? Likewise, you've highlighted a risk that these conversations, the timing of these conversations is now in winter, our busiest time. So if we're seeing that as a risk, why are we doing it in the winter? Because that's what the paper's telling me. And I realise it says in the mitigations, even though it's not a mitigation, that there is no ideal time for this work. So why the winter? Why are we making things difficult if we know they're difficult before moving on? Risk four, many teams have good management arrangements for their service now, and I appreciate the status quo is never an option. However, if they've got good services and good management systems now, what assurances are we going to have that we won't be losing those moving forward, even though there is a nod to that in the mitigation? How will we safeguard that? And finally, and I brought this up in quite a few meetings, risk 6, which is identified that the health board could lose organisational memory as people change roles to leave due to change. I would suggest that the word could should be changed to will, because there is no doubt that people leaving the organisation for whatever reason will take a lot of that memory with them. And the mitigation for that is implementation of change can be phased to further reduce any risk should it materialise. I would suggest it will materialise pretty early on. Those are comments. I just look for some reassurance from Sue. It's not a criticism, these are observations.
Dr. Medwin. Sue?
Okay, so I'll try and take those in turn if that's okay. So the risk in terms of the behavioural framework. So why would we change an operating model without a behavioural framework? I suppose there's a couple of things I would say to that. One is we are changing the operating model based on the feedback that we have received from across the organisation, as well as our own assessment that our current operating model isn't as effective as it needs to be. So the reason that we're changing the operating model and the method of changing the operating model has been subject to significant levels of feedback from staff from across the organisation, linked back to Stronger Together Discovery. We do currently have a behavioural framework, but one of the strongest messages that we've received, both from our workforce and actually from colleagues and conversations at board level, is it is really difficult to do the right thing and to do the right thing on a regular basis across the organisation. That was the feeling of our people, that we needed to, as kind of the 3 points, simplify, modify and unify. And so this is very much in response to. You'll see from the people strategy plan in the last item that there is a whole programme around our ways of working and very much around our values, our behavioural framework, our compact, if you like, between the organisation and the people throughout it. That will be enabled by the operating model, and the operating model will be enabled by that. So I'm not sure whether that's answered the question, but I think, is it possible to change an operating model without a behavioural framework? I would say yes, it is, because often the operating model can inform the changes in behaviour, but also recognising we do currently have a behavioural framework, but it has become lost in people trying to manage within a system that is not as helpful as it could be. We talked about, you asked me the question about the why do it in winter. Again, colleagues will recognise we started discovery in April of 2021. We heard from lots and lots of people, and have continued to hear from lots and lots of people who have given us a mandate to change. We did debate whether to hold off making the changes in the operating model until the new financial year. But actually, there was a resounding will for us not to do that from the organisation. But equally, we recognised we are not going to be able to deliver the level of change that we need to in the organisation, particularly in terms of our delivery to the communities of North Wales, until and unless we change the way that we work as an organisation. And so, yes, there was always a risk that this was going to be very challenging through the winter period, but we have been able to manage it. And actually, it has provided a range of colleagues with a level of hope that things next winter will be different, and it will be easier to do the right thing. I think the next point was around loss of organisational knowledge and memory, and I think you're absolutely right. It should say will. Whether that changes the risk to an issue, I'm sure we could debate for quite some time. We will lose organisational knowledge and experience. It is really, really important that we harvest that knowledge and that memory as much as possible in order to inform our talent management moving forward. We had committed to doing that. So as we know that we've got colleagues who are in very senior and quite pivotal roles in the organisation who will be departing from the organisation, we have involved and engaged and embedded them in the change that we want to see moving forward. We have very clear handover plans and transition plans, but we do also need to refresh as an organisation and build our ability to reset as an organisation as well, and that's where the talent management comes in. I'm hoping I've picked up all of your points, but I may have missed one in the middle, so apologies if I have.
No, thanks, Sue. My concern was that we have a workforce who have been extremely hardworking and dedicated, and to have an operational sort of change within the system or even discussing it is a risk to the service. That was the point I'm making. And also the memory loss, which I think you've addressed. Thanks very much.
Okay, thank you. I think just one thing I would want to say, colleagues will cast their minds back to when we kind of concluded the first wave of discovery, and it was the resounding word of hope that our workforce, yes, are very, very tired, but they also had hope that we mean what we say. We recognise we want to make it easier for people to do the right thing, and I think that's what's carried us through. Yes, it is a management of a large scale change at a point of time that is very challenging, but actually there is still a real will for us to continue to push forward and amend the model, including with those who are directly going through the change themselves. So it looks as though we made the right decision at this point.
Thanks, Sue. Joe?
Thank you. Just to acknowledge Medwyn's questions and to further confirm that we will be working with colleagues who may be exiting the organisation on a phased set of leaving dates, so that we do seek to make sure that we can transfer the knowledge that they do have and safeguard that information for the benefit of the organisation going forward. It is a big change, but we are confident that it is the right organisational model, enabling us to achieve the benefits of Betsy Cadwallader at scale, and the ability to provide personal care for individuals, particularly enabling us to work even more effectively than we do at present with our place-based partners, local authorities, third sector partners, and primary care clusters. Thank you very much.
Thanks, Jo. John.
Thank you, Mark. Thanks, Sue. I've got a number of observations. Some are more substantive than others. Firstly, in the cover report, it talks about testing of the framework, but it's very internally focused. And it just struck me that shouldn't we also test this against some external factors? No, whether that be political change, economic change, or failure of an external service or partnership. The second one is sort of building on what Medwin was saying around risk. I think there was a couple of things that concerns me. One is in terms of the way the risks are stated. It's not the risks are not structured in the way we've talked about risks being structured. So it doesn't strike you that it's following our risk management strategy in terms of how we understand how we representing risks. But I think the other one is in the governance document. There's I think there's a paragraph on page 5 talks about encouraging staff to build risk management into what they do. And I just felt that the emphasis wasn't strong enough. It should be, we expect people to do it. That would be the suggestion for me anyway, because it is fundamental to a lot of what we do. And just an encouragement feels like it's a nice to have rather than it's key. You talked about some typos. There's one I picked up, you may have picked up on page 14 on one of the charts in terms of job title. And then the final one, there's on page 41 of the main model, it talks about the CDIO role and that it would attend PFIG, but it should surely the role also needs to attend PPPH, given that digital's at PPPH and PFIG only covers the information governance side. That was it, really. Thanks.
Okay, thanks, John. So just to cover those points then, and I'm going to try and take them in reverse order. Sorry, apologies. In terms of the CDIO, one of the things that we've been mindful of not doing, I think, as I said at the beginning of my introduction, was changing anything that had previously been agreed, particularly around reporting through to committees. But absolutely take your point that CDIO needs to be at Partnerships, People and Population Health Committee. In terms of the risks, so the risks set out within the operating model document itself. One of the conversations that we've been having before publication of the final operating model document is whether the risks are appropriately set out within that document. So if we're seeing the operating model document as a document that provides clarity as to our operating model, rather than a document that describes the transition, the risks wouldn't necessarily be in there if it is the former. But absolutely take your point that we need to be describing them in a consistent way across all of our documentation. I think the first point that you raised around the testing, had a really helpful conversation with Lucy prior to finalising the document to come to board. Really helpful suggestion that it would be really helpful to see what it would look like in action. So sometimes that helps kind of comprehension, but it also helps to see whether we've got any gaps in our thinking. So that was the premise of the testing the resilience of the governance structure. Almost, I think you've just described a pestle. I think testing the resilience of the operating model using kind of that pestle model. Yes, of course we would do, and we would definitely do before go live on the 1st of July. But we can certainly build that in if colleagues would think that would be helpful. I suppose one point I would also want to draw out that I should have drawn out earlier, apologies, is the point that myself and Jo have made around involving and engaging people from across the organisation, and particularly those people who've worked in in working in senior roles across the organisation, but also some who've worked external to the organisation. They have been really heavily involved and pretty instrumental in kind of designing that. How do we connect the board to the rest of the organisation and align? So colleagues, a number of colleagues have been involved in the development of this framework. This hasn't just been a governance and a people sitting in a darkened room piece of work. I think I've covered everything. If I've missed anything, please do say, John.
It was just the expectation rather than encouragement around risk management.
Yeah, and I suppose, so there is a very clear expectation in everybody's job, in everybody's job description, in all of our policies and processes. I think the word encourage was there to try and encourage the hearts and minds as well as the accountability. But take the point, we can strengthen it. But I do think we need to be thinking beyond the compliance piece and very much thinking about how do we enable people to do things without even thinking, because they know it's the right thing. And that does take a level of encouragement, understanding, development. It is more of the hearts and minds, which would then mean we wouldn't need as much of the compliance, which would be really nice.
Yeah, I take your point. It's not just compliance I'm reaching for either, but it shouldn't be just as an afterthought. It should be fundamental to the way people are working.
Yeah, no, I take your point. Thank you.
Lucy.
Thank you, Chair. Yeah, I think a number of the ambitions and principles described in the documents are really helpful, and I completely agree, Sue, that we have to have that behavioural framework wrapped around this if we are going to make the changes that need to be made in relation to the operating model. You've touched upon how it fits in with the previously agreed operating framework. But it also describes some changes to some of the decision-making forums and the groups, and I'm not sure how that then fits in. So, for example, the executive team as a group, obviously not you as individuals, but the executive team as a group being disbanded and replaced, and the executive delivery groups and subgroups reporting into the committees, I'm not clear how they fit in. Is there a risk of duplication? And there's also reference to deciding strategy at operational level. And I'm sure there are some nuances in here that are difficult to pull out in a written document, but how will that work in terms of the board's responsibility for strategic decisions being made to ensure that the decisions being made at operational level complement those and support those made at board level, and make sure that our strategic priorities are kind of all there. I know it's really difficult to capture that kind of thing in a document, but it's being clear about it, isn't it?
Yeah, okay, so thank you for that, and thank you for giving me a bit of advance notice so I can think about it. So the first thing I would say is in terms of, the executive delivery group reporting lines through to committees, I don't believe that has changed. I think as we develop the exec delivery groups, responsibility in the committees for elements of the plan remain ex ante. They won't change. If we at delivery level believe, okay, so we've got a particular issue that isn't being picked up, it's not quite working, being combined with one exec delivery group, then actually giving that a bigger focus, giving that a better focus, in my mind, then supports and strengthens delivery, and therefore supports and strengthens assurance. So nothing has changed in terms of the assurance or the lines of assurance reporting through to board committees. In terms of the executive team and the proposed health board leadership team, that is very much around recognising that if we really want to make the change that we want to see, we need to involve and engage the wider leadership team in that decision making, in that problem solving, in that pulling together as a whole. And therefore, to do that, we've always discussed the health community directors and colleagues being part of the executive team. We actually then started to work through, okay, so if we really want this to be we're all in it and delivering the organisation's strategy and plans, it would be much better if we're taking cohesive and collegiate decisions for the greater good. Very much reducing some of that silo working, very much reducing some of that different parts of the system playing each other off potentially, which sounds slightly negative, but kind of looking after the delivery in their patch without necessarily thinking about the knock-on effect to other areas. So very much bringing that collegiate leadership structure together. The executive team as a decision-making body would be within the health board leadership team, but the executive team would then be much more focused upon how are we working as a team? How are we making the best impact? Are we horizon scanning? Are we really looking and undertaking our role at that strategic level? The point about deciding strategy at operational level, I think this is, there's something about the terminology that I'm sure we can refine, but very clearly the board's role is to set the strategy and to set the strategic direction. In terms of decision making, that's very clearly set out in the scheme of delegation and reservation in terms of what decisions have to be made by the board, what decisions can be made by committees, and what decisions are executive or operational decisions. There's no intent for decisions that are taken at an operational level to be taken out with pursuance of the strategy, which is why in the diagram tried to represent that the whole of the structure is aimed at delivering the strategy and the plan. Everything is aligned to delivering the strategy and plan, which is why there's an element of replication through the organisation. So there is that golden thread, but not just a golden thread from board to individual delivery, golden thread aligned to delivery of the plan through that structure. Now, it may well be that we've not quite nailed that description in the document or in the diagram. And again, more than happy to refine that if it would help. I do think, though, a lot of this is going to be, the proof will be in the pudding, and we'll only start to find out whether there are nuances in there that we haven't thought about or we'll need to deal with as we start to operate in it. There is something about, and particularly as a learning organisation, doing it, trying it, identifying elements that don't work, addressing those. I think we need to get into that space more as an organisation, because as we know, we think something looks great on paper, then we try it in practice and it doesn't quite work, and that's the whole premise of being a learning organisation, isn't it? But I take the points in terms of some greater clarity in the document.
Thank you, Sue. Just to be clear, by the way, the comments that I was making there, I wasn't saying that I don't think it's a good idea. It's just making sure that it's understanding how it fits in with the governance framework and structure that we had before, and understanding some of those changes.
I understand that, and your support has been really helpful. Thank you.
Me next, then.
I'll let Mark know he's frozen.
Wasn't sure whether it was me that was frozen or Mark. Thank you.
Lucy, would it be okay to see if there are any other questions from colleagues whilst we try and reconnect Mark?
Yes, I think that's a good idea. Good idea, Joe. Are there any other?
Sorry, I'm back. Do you hear me?
Oh yes, thanks.
Sorry. So first of all, Joe, Sue, I think there needs to be another opportunity before that readiness assessment gives rise to a decision to go ahead. Sometime in May, the board meeting on the 26th may not be timely, given you want the risk assessment or readiness assessment completed by the 18th and no later. But I would ask you to consider that, because this does require further board oversight. So out with it here, can you consider that particular issue? But the second observation for me is, I'm afraid to say that I don't think I wish to support the operational framework at this point, given I do think there are a number of things in that document that are yet to be clarified. I would certainly welcome seeing what the response is from the piloting of the framework, which the document says is due to be completed by the 31st of March, before we seek to endorse it as an organisation, as a board. And I say that for a number of reasons, which are our attempt to list here, albeit in a as succinct manner as I can. So first of all, I'm with Lucy around some of her observations. I do not think this document looks complete enough to me. And on the point of providing a link between board and ward, I just can't simply see from this document how that is going to be achieved, not least when there are a variety of statements made in the document which would lead me to believe we're not at a point of being able to understand that. So, for example, some elements of the operational framework are already in place, others can be implemented through the transition phase. Precise structures to be agreed at a local level, but to follow the broad outline at executive level to ensure application of minimum standards. On Lucy's point around the HBLT, I get the wish to extend the representation in the senior decision-making governance sense, but I'm not sure actually that forum can fulfill, as listed, the governance and accountability functions previously held by the executive team as a collective. In truth, there are clearly some clear accountabilities and responsibilities that lie with the executive, and I would want assurance that that is recognised and understood by the executive as a team, because that does not suggest to me that it is. And I would want to be clear then as to what role you feel that the executive meeting as a team in that context will perform, because I don't understand that either in terms of this document. There's reference also to formal and informal attendance at the EMG. I'm not quite sure I understand what that is said to mean. And then going on from the executive point, it refers to, doesn't it, that the executive delivery group will be led by members of the HBLT. So it no longer says the executive delivery groups will be led by the executives. I would want clarity on that point, not least because the name executive delivery group continues to be used. And if it's not an executive delivery group, I'd want to know what it is. And going back to my earlier point, I'd want to know what the involvement of the executive was in that element of the governance framework. It seems to me too, and I know these things are difficult to write and articulate in documentary form, no less. But it seems to me that there are a whole host of responsibilities and accountabilities that are being, in essence, driven down into the organisation, and I understand why, without, to my mind at least, much clarity in terms of what the expectation then is of those leadership teams, and particularly in a structure that's now changing. And I know some of that will need to be worked through, but it does seem to me to be rather complicated. And I think if I was sat in the lower by the pilot, is probably particularly helpful. I'm not sure I would understand, or in the alternative, I might feel I was being given a lot of devolved responsibility without much by way of guidance. And I think I would want to understand that as chair of the board and the board, so as to ensure that the effectiveness of these changes are going to be truly felt, particularly in terms of providing further assurance to the board rather than less assurance. And the risk around this too is, and I know you've responded to this point with Medwin, you're now seeking, or the organisation is seeking to change the operating model, change the operating and governance framework, along with, this document says, alter the performance and accountability arrangements, but there is no description of that in here, at the point at which a significant number of senior managers are set to leave the organisation. And when we know internal audit, and they are not alone, have got concern about whether controlling the organisation will be retained. So I think at the very least, this document requires further consideration and discussion by the board, we need to understand the responses to the questions that I've just posed, and that's not just because they're coming from me, albeit I'm the chair, but others have made similar observations, I think, albeit in a different fashion. And I think the board has got to be reassured, therefore, that the roundness of the changes proposed and the extensiveness of them is fully understood and described coherently to the board, perhaps again on the 30th of March, but perhaps also, as I've said already, on to May, before this wholesale change kicks in. The other thing that I would seek assurance on is I would want to know that the executives in their entirety, but also senior managers in the organisation, are content with and understand what is being proposed in this document and other aspects of the operating model. Because the last thing I think we can do with, at a point at which we are under considerable scrutiny and in receipt of a number of adverse incidents and reports, is to introduce more risk in the organisation that will threaten our stability, performance and public perception and confidence. And I don't think at that point I feel like that with this document. Joe.
Thank you, Mark. So thank you for your comments and observations. What we're trying to generate through these documents and indeed the conversation is a sense of being able to create a framework within which we can all discharge our obligations and responsibilities. You make the point around driving down accountabilities and responsibilities, and making sure, of course, that individuals are clear about their devolved responsibilities, but with guidance and support of the framework around which we wish to support those individuals. And you're right, we are seeking to create an organisational structure which enables our senior leaders, clinicians by background, to be enabled to deliver services to our population and to meet our obligations to Welsh Government and to the board by way of performance standards in a clear and consistent way. You speak about the importance of execs and other senior leaders being content with their understandings and that being in place before we press the go button. And I wholeheartedly agree, which is, of course, why we're seeking to develop the process up to date with this paper, with a strong element of co-design. And that's co-design within the business as well as across the business. One of our dilemmas in working this through is that we have said through the principles of the operating model that there will be some aspects of choice available to the integrated organisations with regard to their own management arrangements. And so we need to enable those choices to be enacted within a shared framework, whilst also being able to provide the assurance to ourselves as executive directors and to everybody on the integrated board. So I think it will be important that we continue the conversations that we've started through this process today, as we move towards trying to balance all of the requirements and respond to all of the observations, comments and questions that colleagues have helpfully raised with us. We will, as a consequence of these conversations, which have been very helpful, need to go back and review some of the practical implications with regard to timelines. And my proposal is that we do that and are clear as we come back at the end of the month, just to make sure that we are all content with our timelines going forward. Thank you.
Okay, so Joe and I, you will link up outside to agree the timeline then. Yeah, and then we'll revise board members accordingly.
Yes, yes.
Okay, and again, I repeat, but we appreciate the what's been sought to be achieved here and the work that's going into this, but we all need to ensure that we understand it, get it right, and are assured by it too. So that's why the comments have been made in that sense. So we'll move on accordingly. So we'll hold approval of this until the timeline's been agreed. Joe, if that's acceptable, then.
Thank you. Yes.
Yeah. Okay. Thanks. Right. I suggest, notwithstanding the fact we are due to have lunch at 1:15, we have a break now. We've been going for some time. There's still quite a lot to get through and quite a lot of important material to get through in some detail too. So I suggest we pause the meeting for 10 minutes and come back at 5 to 12. Is that okay with everyone?
Yes, thank you.
Yes, please.
Okay, 5 to 12. See you in a bit. Okay, shall we resume, please, everyone? So the next item is in relation to regional treatment centres. Joe, are you ready?
I am. Thank you, Mark. Just a very brief update to colleagues with regard to the regional treatment centres. We're continuing to progress our plan to commission regional treatment centres through a revenue funded model. We're working to identify partners who can work with us to design, finance, build, equip and deliver cost-effective facilities across North Wales to enable us to provide robust and sustainable planned care capacity, and would enable us to create green spaces in order to undertake a range of outpatient day case and some more major surgery, as well as the provision of diagnostic services. Work is well advanced within the clinical community to think about those pathways that would be applicable for use in a regional treatment centre, building, of course, on the important principles of transformation and evidence-based practice. We will be bringing a proposal to board for consideration, as already indicated, at the end of this month. And we're continuing to work very closely with our colleagues in Welsh Government with weekly meetings, including one coming up on Friday, in order to make sure that we and they are clear about the programme. One of the things that we will want to discuss when we speak next week are the procurement routes that we wish to proceed with, and be very happy to be able to go into more detail at our next meeting. The business case will need to be read in close collaboration with the planned care aspect of the IMTP. Because taken together, the plans we will present for the short and medium term will form an important part of our proposed planned care recovery and sustainable delivery post-COVID. Thank you very much.
Thanks, Joe. Any questions? No, okay, so we'll see it back, Joe, on the first year. Thank you. So I move us on then to the quality, safety and performance section. And the first matter here is the Committee Advisory Group Chair Assurance Reports. I'll go through them in order. Cabinet, I have nothing to highlight. It's there for information. Anybody have any questions about the report? No? Lucy, the next two are your South and QSC committee matters you might wish to highlight.
Thank you, Chair. So as the board will be aware, we've received a number of reports recently at QSE committee that have raised significant concerns about the care of some of our patients. In January and March, we discussed the serious incident review reports for Hurgest and Llywelyn and the associated action plans being developed. I just want to be clear, members did have a copy of the full reports for both Hurgest and Llywelyn. The committee has asked for revisions to be made, however, to the action plans, particularly Llywelyn, so that the actions are less transactional, adequately address the findings and can be clearly measured so that the impact and improvement is clear. In terms of the two mental health reports, the division are working with the transformation team to develop an improvement plan for the services as a whole and then across the health board. This is a different approach than has been used before, and it's a very welcome move away from the production of an action plan, which has been a previous approach. And then that previous approach then has not been able to sustain the right improvements that we need to be able to deliver. The committee will receive the revised plans at the meeting in May, and it's proposed that it's then presented to the board for assurance. Board members will note in my report the concerns that the committee have raised about the recurring themes arising from various reviews lately for the health board, and we've asked for these to be considered in the clinical audit plan so that we can see evidence of those improvements. In terms of vascular, it is on the board agenda, so I won't go into too much detail other than to confirm that I've met with the recently appointed chair of the vascular quality panel, and we'll be receiving regular updates as to the findings of their review, as will the committee, of course, on the board. Another matter to be escalated to the board is the committee's concern about the patient safety reports that have been presented to us. The committee need to be assured that change is actually happening as a result of learning from incidents, and we're not currently assured that this is the case. The health board must be able to evidence the learning and to be able to demonstrate that it's sustained learning if we are to improve the quality and safety of care being provided to our patients, and that people can be confident of the care that they will receive from us as a health board. So the committee is asking for the board to note the concerns about the patient safety reporting, which was due to be submitted to the meeting today. Apologies, my report says the 15th of March, but it was actually today. An improved patient safety report will be presented to the board on the 30th of this month. And the board is also asked to approve the approach to monitoring the action and improvement plans for mental health and vascular services as detailed in my report. Thank you.
Thanks, Lucy. John?
Right, back. Just a quick one, Lucy, with regard to your second report, there's reference to a CCTV policy. And given that we'd raised previously at board some concerns about how CCTV was being handled, I wasn't sure what the content of the policy was, because I would have thought it might have come under information governance or digital.
Okay, thank you for that, John. I will, I can see Sue wants to respond to that, but I'll just quickly respond and then hand over to her if that's okay. Basically, it's come to the QSE committee because it comes under the banner of health and safety, and the health and safety reports into QSE committee, but I'll hand over to Sue.
Thanks, Lucy. So as Lucy said, it is under the auspice of health, safety and security. So that's why it's gone through the Strategic Occupational Health and Safety Group and the QSE. It has been developed in conjunction with IG colleagues. More than happy to provide a copy for assurance purposes through PFIG, if that would be helpful. Thank you.
Happy, Sue, with a copy through PFIG, or even just outside of this, if you just want to bounce it off me, I'm happy to look at it just from an IG point of view and PFIG, and then if we need to do anything further with it, I can come back, can't I?
That's great. Thanks, John.
Okay, thanks, both. In terms of the first matter for escalations to the board, the safety report, Joe, I think you and I need to agree for it not to come on the 30th of March will be somewhat unacceptable, and the report has got to be landed in time for that committee. It was identified as a matter requiring action because of the risks associated with the current reporting arrangements. So this matter has to be settled, and it has to be settled quickly.
Noted. Thank you.
Thanks, Joe. And in terms, Lucy, of the board being asked to approve the approach to the monitoring of the action and improvement plans for mental health division, I think that's absolutely right. Our colleagues happy to support the approach that Lucy's articulated.
Yes.
Yes.
Thank you. Thanks, Lucy.
Thank you.
So I'll move us on again. The next assurance report was in terms of PFIG. John, anything you wish to highlight?
I take the report as read, but I think just the risks, maybe some things to pick up on. One was the risk from increasing energy costs, despite the fact that we're forecasting and continue to forecast a balanced outcome. That's an ongoing concern, I think. I think there's also an ongoing concern about the ability to deliver recurrent savings, which is going to be key in our transformation and the IMTP process that we go forward. Recruitment issues were a continuing theme, and and in particular, we had some concerns around unscheduled care, such as ambulance handovers, but we are aware there's focus work going on to sort of try and address that. And I'm sure if Jill was here, she'd be able to comment further. There were some also increased additional costs around from some external contracts, which were raised a little bit of concern, but I think it's being managed at the moment in terms of our overall forecast of progression. I'll leave it there.
Thanks, Sean. I think you you noted the Cernic post-project evaluation.
Yes, forgive me. That was a real positive in terms of the post-project evaluation, in terms of the work was done, what we've achieved in terms of not just achieving the benefits were laid out, but we're exceeding that, I think. And I think formally, I think we want to sort of commend everybody that was involved in the project in terms of its delivery.
Thanks, John, and we can do that as a board. Thank you. Lynn?
Sorry for the delay. John, you mentioned that you received a paper on discussing the planned care challenges and the fact that the Welsh Government had set out targets, and your next meeting is on the 24th of March. Can I assume that that will be one of your main agenda items for March? Because later on, when we look at the quality performance, I was going to ask questions at that point.
Eileen, no, the 24th of March is a very extraordinary meeting. Just looking at IMTP, it's a very restricted agenda. So the next.
Okay, I'll leave my questions till later on in the agenda then. Thank you.
Thanks, Lynn. Thank you. Thanks, John. So I'll move us on again. The next assurance report is in terms of PPPH. Linda, anything you wish to highlight?
Na, dim ond i ddiolch I partneriaid ni am y trafodaethau adeiladol iawn, enwedig yn ymwneud â strategaethau newydd. Roedd risg wedi codi yn y modd bydd y bwrdd partneriaeth yn cael ei cyllido o hyn ymlaen, ac mi nath y pwyllgor cytuno mi fyddwn ni'n monitro'r sefyllfa ac wrach cydweithio gyda PIFIG ynglyn â unrhyw effaith ar cyllid yr bwrdd iechyd. Ond mi oedd hi'n cyfarfod adeiladol iawn a dwi'n hapus iawn I cymeryd unrhyw cwestiynau.
Thanks, Linda. I can't see any questions, so I'll move us on. The final set of minutes was note was in respect of the targeted intervention steering group, and we've had a discussion on that already, so I don't intend to dwell there. So I'm going to move us on again to the vascular services update. Nick.
Thank you, Chair. Board colleagues will need no reminder of the importance of this area and the need for us to continue to ensure that we are improving vascular services for the population of North Wales, the population that we serve. This paper summarises some of the key actions that are taking place in response to the two parts of the Royal College of Surgeons review that the board commissioned in 2020, as well as internal incidents that have arisen and the results of national audit. This paper was actually written before the QSE meeting on the 1st of March, where detailed consideration of the vascular improvement plan took place. So those of you on QSE will see some asynchronicity in terms of the reporting, for which I apologise, but that was inevitable. This summarises some of the vascular steering group actions. The vascular steering group, of course, is an internal meeting, but one on which the Community Health Council are also represented. I will, if I may, Chair, assume that the paper is read, but just highlight the significant progress in response, particularly to the second part of the college review, the establishment of a vascular quality panel, and work going on literally as we speak to establish communication with the families and the patients affected by that review. There's a great deal of work taking place to enhance the strength and in terms of both of capacity and expertise in leadership around vascular. And I'm very pleased to report that our working with colleagues both across Wales in developing a community of practice for vascular services, but also more tangibly with Liverpool in terms of improving our MDT working and communication proceeds at pace, and is very helpful. I'm very grateful for the support that we're receiving to that end. Workshops have already taken place to take forward teams' understanding of professional standards, which is highlighted as a key issue within the RCS2 report. And we have established a weekly review of vascular notes across the whole of the health board, and a rapid improvement cycle is showing significant improvements in that quality of note keeping, the breadth of the medical records available to the multidisciplinary teams, and also in consent. I'm happy to take any questions, Chair, but I would highlight that this is a very dynamic and changing situation. We continue to monitor the vascular improvement plan on an almost daily basis to ensure that we are responding. We are checking that progress is proceeding in the way that it needs to be, but also as and when any incidents occur or we are aware of any further information, challenging ourselves to ensure that that vascular improvement plan is providing all of the actions that are needed to ensure that we provide safe services. So happy to take any questions, Chair.
Thanks, Nick. Lynn.
Thank you. Nick, you touched upon the review group doing some work on communications with patients and stakeholders concerned. Could you expand upon that, please?
Thank you, Lynn. So the Vascular Quality Panel, chaired by Susan Aikenhead, a very senior and nationally respected nurse, has commenced an initial commenced the process of reviewing both the notes that were submitted to the Royal College, but also additional internal notes supporting those 44 patients and their experience within the health board going back to 2013. We will be writing in the next few days to patients and their families who are a part of this review, inviting them to get in touch with the health board should they have any immediate questions, and are now establishing a protocol to ensure that we share information as and when it arises, both sensitively and appropriately. Because what we really need to do is just to be open with the families where there are lessons that we need to learn and where potentially we need to carry out further treatment to support them. I hope that answers your question then.
Yes, thank you.
Thanks, Lynn. John?
Yeah, thanks, Chair. Thanks, Nick. Nick, for the report. A couple of points, if I may. Within the report, it talks about the report that's going to come from CHKS. It says that the report was provided in or completed at the end of January, and yet the covering report that we got this morning is talking about the methodology and detail of this report is currently being reviewed. So first of all, the question would be around the context of that report and whether there are aspects of that that need to be addressed urgently, because from a time point of view, that report was presented initially at the end of January, and yet it's not going to the new oversight group until the end of March. So we're talking around 6 weeks from when reports are coming through into action. You mentioned in relation to reports and notes for patients, yet again, there seems to be recruitment issues because there's a reference in the report with regard to the need for more staff to be involved with data entry. So I suppose the board is looking for an assurance with regard to how close are we now to actually being sure that we're having 100% accuracy in terms of reports for patients, because we're aware that the Royal College obviously identified significant issues around patient notes. And the other particular point is in moving patients who have previously been defined as requiring vascular surgery now being moved into orthopedics. I wonder if we could have some clarity with regard to the distinction that will be taking place between those that would have gone through a vascular route now going through an orthopaedic route. And in particular, the issues that have been highlighted with the Royal College. I would just like clarity whether from a medical point of view, the issues were associated with vascular elements of the care, or whether it was actually associated with amputations, because if it is clearly amputations, moving them into another service area is still creating a potential risk. Thank you.
Thank you, John. So if I may take those questions in turn. First of all, in view of the CHKS being an external company who we already work with, who we approached to settle once and for all our understanding of the outcomes for patients in the vascular service pre and post the centralisation of service, the network model that we've now adopted with the hub and spoke model that we adopted in 2019. As you rightly surmise, the report was received, but the report didn't give the detail in order to be able to give clarity as to whether or not there had been any change in outcomes during that change in our service provision. So we have gone back to the company to ask them to look again at the data, to look at the methodology in order that, if at all possible, I can come back to the board through QSE in order to give that clarity of story as to whether outcomes have changed, John. I would prefer to wait and come back with robust data that we all understood, where the methodology was absolutely clear, rather than come back with a story half told. In response to your second query about recruitment, the quality of the clinical record is, of course, largely down to the clinicians who are entering information within that clinical record. And board colleagues may be aware that we have started the use of a digital health record, an electronic solution to some of our recording in vascular as a priority, and the first pilot of that has now commenced. But you're right to highlight that it's not just the clinical entry, it's also the support staff who collate those clinical records, make them available to the team, and provide some of the data entry. And within the IMTP proposals, there is detailed work carrying on now to ensure that that is available, not just in the Glenclwyd site, but in the two hub sites, Bangor and Wrexham, that feed into that. That work proceeds, John, but I'm not able to give you a final version of what that resource needs, but suffice to say it will happen. In response to your third question, I suppose if perhaps I could just go back one as to this. There is no change in terms of patients who need, patients who have a need for surgery or review, who have large vessel disease, disease that needs the expertise of a vascular surgeon, will continue to have that, whether that review takes place at one of the spoke sites or at the hub in Glenclwyd. And there is no proposal to change that to another part of our service. So those patients who need vascular expertise will continue to have vascular expertise. However, there are some patients, particularly in relation to the diabetic foot pathways, where actually the care may be more appropriately provided by an orthopaedic surgeon, by a physician, by a general surgeon, or indeed increasingly by clinicians who are not doctors, who are often in a far better place to provide that quality of care. So the pathway changes are not about moving patients from vascular to somebody else. They're around providing absolute clarity as to who is the best placed clinician to treat each and every patient at each point on their pathway. I hope that answers the questions, John, but please come back to me if that's not clear.
Yeah, thank you, Nick, for that clarification. It certainly helps in terms of putting some of the things into context. Could I just pick up on one other point which was included in the report, and that refers to the recruitment of a specialist foot and ankle surgeon. I think this has been talked about for some considerable time, and I just wonder, is this just another role where we're struggling to recruit to, or where are we actually up to in terms of that process to have the identified surgeon being able to be in place to actually carry out that particular work? Thanks.
Thank you, John. This relates partly to the clarification I was just referring to around who is best placed, whether indeed it should be a foot and ankle surgeon, or whether we could do something slightly more innovative, as is being done in other parts of the UK, for instance, around appointing a consultant podiatrist. And grateful to AHP colleagues for taking those ideas forward. So part of this is because of recruitment challenges, John, and making sure that whoever we go out to recruitment for is somebody who is going to be available, but it's also around the clarification of what our service really needs to ensure that we have the right people in post.
Thanks, Nick.
Nick, Sue G, can the board just be assured that yourselves are drawing together the detailed proposal around additional workforce requirements that's referred to in the report, including the diabetic foot service? Yeah, are you working together and at speed to arrive at a conclusion in terms of what's required, and then to secure what we need, if at all possible?
Chair, we are, and indeed Sue and I spoke only yesterday around some of the adverts that will be going out either tomorrow or on Monday. There is some prioritization of this initially around medical staff. Medical staff are not the only clinical staff in these pathways, but there are particular issues around ensuring consistency and sustainability of some of our aspects of our vascular medical staff. And then there is a phased approach to ensuring that we're able to advertise high quality staff at pace into other parts of the pathway. One thing I would want to assure you, Chair, is services across the country occasionally make the mistake when services are under pressure of taking shortcuts in recruitment or taking people who are not of the highest quality. And I think Sue and I would speak as one to say that that's not something we are prepared to do, and we will be recruiting only the very highest quality staff.
Thank you. Sue, anything from you, or has Nick said it all?
I was nodding profusely, Mark, as he was talking, yes.
And in terms of recruitment, Nick and Sue, we normally have independent member involvement in terms of consultant appointment. Is that the intention here?
Yes, they have to be appointed through an AAC.
Thank you. Nick, can I then put you on the spot to a degree? So when you, I, Lucy, Joe reconvene in a month's time, or a bit less than that, what improvements in terms of progress against the many recommendations, concerns identified would you expect to be reporting to us in a month?
Thank you, Chair. I would expect that we would have clarity of where we are in the recruitment pipeline. I would expect that we would have in post enhanced leadership in vascular, particularly around the professional standards. Part of that, we've been very fortunate in securing the services of some nationally respected individuals, and I would expect at least one of those to be in post in a month's time. We will be seeing the first communications and views from the vascular quality panel, the rapid improvement cycle in terms of quality of notes, quality of consent, which leads on, of course, to quality of team working. We would expect will be continuing and will have continued over the coming month. The close working with Liverpool, the MOU, the Memorandum of Understanding with Liverpool, has been agreed in principle. That is not all within our gift, Chair, because clearly there is the Foundation Trust in England is a partner in this, and we are awaiting we'll be awaiting their signature. I'm optimistic, but I'll give you no assurance that will be signed. But what I can give you assurance is that closer working with Liverpool and other colleagues in the Northwest will continue. Key for me, though, is this professional standards work, the work with the General Medical Council and the Nursing and Midwifery Council, working with our clinical teams on an almost day-by-day basis to make sure that that understanding of their responsibilities and their personal responsibility for those standards continues. I could go on, Chair, but I hope that summarises some of the key areas.
No, it does summarise some of the key areas. Thank you. Nick, one final point of clarity for me, please. When do you think we will have a sense as to whether, albeit we now know that the full records were not submitted to the RCS, when we will know whether some of the issues associated with quality of clinical records extend beyond vascular?
I think we already know, Chair. We already know that the issues for note keeping we already know that they do extend beyond vascular. The extent of that and the impact on the quality of care that we offer our patients has yet to be determined. I think rightly the hospital management teams are concentrating initially on vascular. We have seen that progress in quality, huge progress in the last 3 or 4 weeks. In discussions, we are now beginning to extend that more widely into areas such as urology and other general surgery areas to understand, and in a month's time, I think we'll be clear what that is and what immediate actions we may or may not need to take place. But I think, Chair, that the fuller answer to your question is that within our clinical audit plan for next year will be a comprehensive approach, not just to the quality of record keeping, but also to consent, DNAR, the way that we record the deteriorating patients, and other themes that have been fundamental to quality and safety that the board is all too familiar with.
Can I ask then of you and Joe, that of course we will receive a vascular report again at the next meeting by QSE, but there ought to be an update, Nick, which extends beyond vascular in terms of those broader issues, one of which we just touched upon. And I think we need clarity as a board on those concerns and issues as they are being reconciled or not in terms of what's been found in the organisation and where they are being identified as broader concerns, the proposals in terms of remedial action.
Very happy to do that, Chair. I would suggest that we need to work also with Lucy as Chair of QSE to make sure that there is a clear reporting process and that feeds not just into the immediate response to that question, Chair, but also into that longer term improvement.
Thank you. Joe?
Just to say yes, we are required, as you know, you're required with our input to produce a monthly letter to the Minister, and at the 3 months point we are asked to include a view on the quality of medical records, for example, in a more fulsome final monthly report. So I think it would be helpful working through the chair of QSE committee to put those processes in place.
Thanks, Joe. I won't ask Lucy because I know Lucy will pick it up. Okay, thank you. I'm going to move us on then in terms of that report and noting its contents and the update from Nick to the quality and performance report. Sue, are you having this to start with?
I am, thank you, Chair. So just to introduce the report, I would just like to assure the committee around the work we're doing around the performance reports. We did discuss it in some detail during the action log, but the development of the new performance reporting system is underway and incorporates the detailed feedback we've received as part of the engagement from board members. And the current timeline will deliver the integrated performance report live for April 2022 data, and it will be aligned to the new operating model where that is required. And then the first time we will see the report will be the Health Board on the 26th of May. We'll receive the old version, with the new version with the April 2022 position, and then it will go to the committees from that point onwards. The QMP report has an overall summary dashboard of graphs and charts, and it also has an executive summary. And there are probably a couple of points that I'd like to highlight before opening the discussion to any questions that board members may have. So in terms of unscheduled care, pressures on the unscheduled care system remain. And although performance remains well below the 95% target for patients to be seen within 4 hours, at 62.07% in January, it is an improvement on the position in December. But we are not alone. This is a pressure that is being felt all across NHS, both in Wales and in the UK. And I think it is a symptom of the number of patients that we have who are medically fit to be discharged in the system. So this really requires an integrated action plan from health and social care about how we can support our patients better, so that we don't have that congestion in our ED and MIU areas. In terms of planned care, as with the rest of the UK, disruption has been caused significantly by COVID-19 and more recently the Omicron variant of COVID-19. But we are doing everything we can to mitigate that. Obviously, our reliance on NHS providers in England is being hampered as a mitigation tactic because of the pressure that they also have within England for their own patients. But we are doing what we can around outsourcing and insourcing contracts in order to try and reduce the risk of harm to our patients. Just in terms of mental health, the division continues to face challenges in achieving and maintaining compliance around the mental health measures. And I've got some information from the mental health division that I can discuss when the questions come up, if any questions come up around that. But we are looking at the pathways as well as the sort of the current service provision, and we've got to see what we can do to address that going forward. At that point, Chair, I would be happy to take any questions.
Thanks. So Joe's hand has gone up. Joe?
Thank you. Not questions, just some assurance on the unscheduled care aspect of our performance. We, along with all health and local authority organisations across Wales, are taking part in what we're calling a system reset at this moment in time. And I would just like to call out my thanks to the support that we've received from all of our local authority partners in this work. This is a really strongly focused attempt to deal with two particular issues which are impacting on the health and well-being of patients in North Wales. The one being ambulance delays, and the other being the numbers of patients who are ready for discharge. The impact thus far of the system reset is already helpfully in play. For example, with a stronger focus on the longer waiters, we're seeing that the length of time that people are waiting for discharge, long waiters, by which I mean waiting for discharge, is starting to reduce on an average day-by-day basis. The numbers of patients who may be suffering a delay is still looking like a stable number, but the number of days that patients are being delayed does look like it is reducing. We are seeing a link between nurse staffing and ambulance offload delay, which of course is one of the reasons why the board has already supported the business case for investment in emergency department staffing, not just nurses, but nurses being a significant component part. We are through this work indicating that possibly as many as 30 ambulance journeys a day, so patients being conveyed to our emergency departments, would be better suited to an alternative pathway. And I'm pleased to say that our Falls pilot, which is currently in play in the east part of our healthcare system, is looking to be very positive, and we're particularly keen to roll that Falls pathway out, not only in centre where the number of ambulance conveyances are the highest, but across the organisation as a whole. The focused attention of the system reset has also drawn our attention to delays that patients face awaiting transfer to some of our tertiary providers. They in turn are also under bed pressures, but we are able now to understand more strongly those particular inputs, and also focus on issues where our own patients need to transfer from one of our hospital sites for good clinical reasons. We've also been trialling working in a slightly different way with our therapy colleagues in order to support earlier discharge. And of course, colleagues will be aware again from our urgent care improvement plan that our next phase of development is around the formalisation of the same day emergency care centres across our sites, and looking at the discharge to assess a pathway that has been particularly strongly developed in the east, ensuring that can be rolled out across each of our localities. So much work in hand with regard to the system reset. I think we acknowledge that across each of our geographies, there are some consistent practices that are increasingly being rolled out, and there are by necessity and design some differences in approach, bearing in mind our partnerships with each of our local authorities does enable us to tailor our responses in line with the requirements of each of our local services. So a really good piece of work, which is current, which is active, and is making a difference to our urgent care performance. Our single largest challenge remains capacity to support safe and appropriate discharge. And we continue to work strongly in partnership with our local authority colleagues and other providers in order to seek to meet many more of our domiciliary and home care and residential nursing care packages. Thank you.
Thanks, Jo. That was really helpful. Thank you. So I'm going to come to some colleagues. Lynn first.
Thank you. Could I take us to page 22, please? The planned care measures. Some of these figures are from December and January, and I'm a little bit concerned as to the trajectory of meeting any or all of these targets. I've seen all the following pages about the actions and the mitigation, but I don't get a feel that much or and I'd like to be corrected to say I'm wrong, that we're on track to even reduce the figures further, never mind actually reach the targets. So I don't know if someone's got an opinion as to where we are right now.
Chair, shall I start? I think, Lynn, your question is a really opportune one, but our issue is that COVID, whether we like it or not, has had a significant impact on our ability to deliver on these standards. So if you think about the proportion of this year where planned care work has been paused for all the right reasons to try and keep both our population and our staff safe, and we are doing everything we can to pick up on the planned care work now. But there are a number of those targets that we are unlikely to meet. So I think a good example is the cancer treatment target. So this is the newly defined cancer pathway where we have to have been seen within 62 days. We are one of the best, in fact, we are the best performing health board in Wales on that target, and our performance has been between 67 and 74% this year. But looking at the trajectory, it is unlikely now that we're going to meet that 75% target in this year. But we are doing what we can now to make sure that we've got the right capacity in place so that we can move delivery and progress that during next year.
Yeah. I accept that, Sue, and I fully understand the position we're in, but shouldn't there be somewhere in these papers that highlight, give us a red flag that we are, for all the actions that are being quoted, we are not making the improvement that we hoped for, and what is implied by all the narrative in the charts?
Just thanks, Lynn. So Joe and I had a conversation, Joe, yesterday around this report and enabling the board to understand what are the things that are being planned that are most likely and most significantly to have an impact on unscheduled care and planned care. Now, I think Joe has described some of that in terms of unscheduled care, but we need a similar description around planned care. I think and I know we're reviewing these reports, Sue, but there is undoubtedly a lot of detail, a lot of actions described, but it's very difficult to pull out of that. What are the fundamentally the big ticket items in all of this, and when can the board expect to hear a report on the progress, implementation, call it what you will, of those big ticket items? Because at the moment we have a lot of information, a lot of actions, but the dials aren't turning, and that's not helpful, is it, in terms of gaining some assurance that as we move forward there is going to be improvement. And I recognise, like Lynn, the challenges in all of this, but as things stand, unscheduled care is red, planned care is red, mental health is red, largely. So we need to understand where we are going to get a sense for improvement being seen and delivered in a realistic sense, and where the big ticket items or opportunities lie in what you are proposing to do. Joe, is that a fair reflection of the conversation yesterday?
Yes, Chair, it is. We also talked about taking the opportunity to undertake deep dives into particular service areas, and to ensure that our risk work has a strong link to not only our performance issues, but also to drive some of the work that we can undertake as part of our regular walkarounds, and then link the deep dives to those issues of risk and concern. Yes, it does reflect the conversation we had yesterday, and of course reflects the ongoing work to develop a different approach to performance reporting, which we've discussed across a number of meetings, and indeed in this board meeting earlier on today. Thank you.
Okay. And I know Chris wants to come in. I think, in short, in terms of Lynn's point, it would be helpful to see a clearer articulation around planned care, Joe, in the way you describe unscheduled care. you know, Chris may be about to describe it, but no matter what, I think a description of what we rely on around planned care improvement moving forward will be helpful. And we might come to other areas in this report in a moment. Chris?
Yeah, thank you, Chair. I was going to come in to just support Sue in the response on planned care. The first point was just to remind us that the period in reference here coincides with the peak of the Omicron outbreak. So I did see a slight reverse in the figures, but we are now back in terms of recovery mode across all areas of planned care. I do recognise that doesn't come through in these present visuals. However, the IMTP is coming to us on the 30th, and that does have the planned care recovery plan within it. So that will go some way to filling that gap, I think.
Okay, thanks, Chris.
Chair, I guess the final point I'd make around planned care is obviously we get both planned care and unscheduled care updates to PFIG. And if it would be helpful for the board to receive similar papers, summary papers, and that is something that we can provide as an appendix to this report to provide that different level of detail. With around the planned care, we're doing everything we can to increase that activity. So we're looking at outsourcing specific key specialities like cataracts, orthopedics, dermatology. We're also looking at elements of insourcing. So we are looking at whatever we can do to increase the capacity that we have across the North Wales network.
I think that may be helpful and one for you and John to discuss. Yeah. I do think there's a broader point around assurance. You're right in that regard. We don't want lots of data and actions. We want a clear sense of, as I say, the significant steps that may be being planned or are being planned to move us forward in terms of performance and improvement. So if that could be the focus, that would be helpful, I think. Lucy.
Thank you, Chair. I've got a number of points to make, but in the interest of time, I'll just summarise the key points, if that's okay. First of all, there are a number of errors, again, in this report. There are the arrows, for example, as an indicator for whether something is performing over or under target. There's examples on page 22, page 33, page 37. You advised before that you'd implemented an additional accuracy check for this report. Has this been done? And the second accuracy point that I want to raise before I move on to my other points is that on page 7, the report makes reference to there being no new never events during the period in question, November to January. But the QSE committee reports for January and March meetings report 3 and 1 respectively. Now it's difficult to identify exactly the dates and whether that is an issue with the dates that the never events were reported as opposed to the dates that the never events occurred. But that in itself is concerning. So I'm not clear, therefore, what is accurate in this report and how it's been actually reconciled with other sources of data. And perhaps if you'd like to answer that, and I'll then ask my next question.
Yeah, thank you, Sue. So just in terms of the arrows, so the arrows, the description of the legend is on page 5, and it's not about whether we've hit the target or not. The arrow relates to a 6-month trend of the data. So we could be below the target, but if over that 6-month period we have been improving, it will be green. And if it's been deteriorating, it will be red. If it stayed the same, it will be amber. So I think that might be part of the confusion, but I'm happy to take that offline if it would be helpful. In terms of...
Sorry, Sue, no, we've talked about this before. That's not the case here. We have talked about this before, and I just think we need to be confident about what those arrows actually mean. But let's take it offline.
Okay, let's do that. Take it offline then, and let's try and resolve it once and for all, as you say. Lucy, I think you said you had other questions as well.
It's okay. So I think that the question about the never event Lucy, the information in the report is provided by the same team, so it's the quality team. And I've checked that with Matthew. What he said around that, the Never event, is there was an event in October that was not notified to January, so he has provided the data in the same format. So effectively that there are no Never events in this period because it wasn't reported until January. So if additional narrative would be helpful, I can provide that in the report, but you know, it's the same team providing the data. It's not something that the performance team pulled together.
No, okay, so I appreciate that, Sue, but in fact, this report covers until the end of January. So that explanation doesn't make any sense. And my concern is around the reliability of the report and what checks are going into it to make sure.
Yeah, I think if you look at the Never event metric, it's covering the Q3.
Okay. Okay.
Let's take that outside too and reconcile that as well, please.
Thank you.
Did you say you had other questions?
Yes, please.
Okay,
so the updates against workstream 1 on page 15, it refers to it makes reference to continuation of current developments. But this doesn't really address how this will have an impact on the performance in this particular area. So a question, for example, is whether the constraints on increasing capacity for the urgent primary care centre in Wrexham, have these been addressed? Page 18 refers to referrals from the emergency department being, quote, actively encouraged. I'm a bit concerned about the wording of that. And has a review of the referrals pathways been undertaken as previously discussed to ensure that the impact of the urgent primary care centres are being maximised in terms of our unscheduled care programme? Thank you.
Joe's hand is raised. And Joe, did you want to come in first? And I'll see Sue's put her hand up. So I'll go to Sue after you, Joe.
Yes, thank you, Chair. In one of our quality and safety walkabouts, the Chairman and I had the opportunity to discuss these matters with ED staff, and they were able to provide us assurance that an audit is ongoing with regard to the appropriateness and number of referrals in and out of the emergency department and the urgent care centre at the Mylor. The individual members of staff present at the meeting were able to very clearly describe the opportunities that the urgent care centre provides for the emergency department. Its close co-location is incredibly helpful, and utilisation they feel can be improved by a joint consideration of risk thresholds with regard to triage and referral. That work will commence once the audit of current activity, both within the urgent care centre and in ED, to identify any suitable patients who were seen in ED that could have been seen in the urgent care centre, who may have been transferred inappropriately. So I think the view was that that piece of work would be incredibly helpful. Thank you.
Lucy, did you want to come back on that topic?
Yes, thanks for that, Joe. I'm not quite sure how that answers the question, though, I'm afraid.
Do you want to repeat the question?
Yeah, so it's how the outputs of the workstream 1 are actually going to be impacting on the performance in this area. And whether or not the review of the referral pathways, and I'm not just talking about from the emergency department here, but the review of the referral pathways that I've previously discussed, has that actually been taken forward? So an example being the double handling, for example, of some of the referrals from GP practices into the urgent primary care centre. it seems that there would be a more efficient way of actually dealing with some of these situations and these patients, particularly as the public at the moment, they seem to be of the view that it's either their GP or their emergency department, and it's that we have an opportunity here to try and, in line with the Help Us to Help You campaign, to try and make those pathways as easy to access and as efficient as possible for our patients.
Thanks, Lucy. Jo?
Thanks, Lucy. I think you're quite right. I didn't answer that question. I was barking up a different tree there. So I don't have a detailed answer to the question on double handling of primary of patients from a primary care point of view into the urgent care centre point of view. I think either others may be better placed to answer, or if we don't have a response to that here today, we can clearly get back to you with a response. Thank you.
Thanks, Jo. That would be much appreciated.
Chris and then Nick.
Thank you, Chair. Yeah, I prefer to come back to you, Lucy, if that's okay, simply because I know that we have had this conversation with the Unscheduled Care Programme Board, but Jill is the SRO and she's not here today with all of the detail, and I'd rather give you that rounded detail rather than just the elements specifically about primary care, because the point that you've made in terms of the opportunity in supporting inappropriate or unnecessary attendances to ED also needs to be included.
Thanks, Chris.
Nick's lowered his hand. So, Chris, your response to Lucy on that point, Ben?
Yes, I will.
Thank you. Okay, I'll come to Cheryl now.
Thanks very much, Chair. Just turning to the neuro and the CAMS indicators, the improvements. I'm really pleased to see that after all this time, and I think the work being put in and the reorganisation is finally beginning to bear fruit, so that's really encouraging. Unfortunately, adult mental health is disappointing and links back to our previous conversations regarding seeing real improvements from our targeted intervention. Meeting with Ian and Mike and Teresa regularly, I know they're very focused on real, actual, measurable improvements in the mental health service for our patients, and we'll continue to push on that. So thank you.
Teresa, do you want to respond?
Diolch yn fawr iawn, thank you, Cheryl. The team are focused on making a difference. Oh, I'm in a funny position.
You're not very loud either. That's better.
Is that better? Apologies, I've been on another Zoom. The team are committed to making a difference, are very focused, as you say, Cheryl, so thank you for those words. Clearly, we need to do more. That's about us being very clear on those actions, working with the teams owning the challenges, and us making a difference. We have been in a better place. We are seeing quite high demand. We're also seeing significant sickness, although better than it's been within the team. So we will keep working on it, and we'll keep working with you in terms of that TI space, but also with the Vice Chair in terms of the mental health piece as well. What I would say is that some of the foundations that we're laying through the TI work are just that. We are going back and making sure that the foundations are right. That will mean that it will take some time to see some of the changes at the top end in terms of performance.
Has everybody else lost Teresa?
Yes.
I'll give it a couple of minutes on. Cheryl, we'll come back to that when Teresa gets back in. I'll move us on. John, do you want to?
Thanks.
Thanks, John.
Yeah, thanks, Chair. Obviously, this report, by its very nature, says it's the Health Board Quality and Performance Report. So I'm assuming that should be covering everything primary and secondary care. And yet within the report, we have nothing at all there in specific to do with primary care. Obviously, the entry point for the public is primarily, in a lot of cases, through primary care. We hear lots of issues over access through primary care. We also hear issues of people who've been in through secondary care, whether it be ED or for other admissions, and then being discharged into primary care and the difficulties there. I just wonder, from a board's point of view, what kind of information are we actually able to access around primary care, and why we're not actually including that in what is appears to be the holistic report. Just for an example, if you actually do a word search on primary care, there are only 6 references, 4 of which are actually all to do with urgent primary care centres. So it's a real concern, I think, from the public point of view, that we're not actually revealing that type of information on primary care. Thanks.
Chris.
Thank you, Chair. I couldn't disagree with you, John. As you know, I think the point that you make is well made. I guess there are a couple of issues. The first is that there is data that we can put into a quality report, and I think there is a conversation to be had then in terms of what primary care data do we put in this, and do we make it longer, or do we take other things out, of course. That will then lead to another conversation in terms of the limited information that we have for primary care, which you did allude to. However, there is no reason why we can't include that limited information, and there is no reason why we can't then have a conversation in terms of how much do we want to commit to filling some of the gaps that then arise when we look at the limited information. So I will work with Sue outside of this meeting with the information that contractors currently have to give us, and which we have in a validated format, and then perhaps if we can include that as a first step and open up the ongoing conversation thereafter.
Can I just come back on that, Chris? Because I mean, obviously we have managed practices as well as contracted services. So obviously that's under far more control of the board directly. One of the real concerns that I have is that we've got significant number of people waiting for secondary care. And I think the question should be asked is, what support are they actually getting from primary care whilst they're actually waiting for their secondary care treatment? Because that, for the public, is one of their key issues, is they feel unsupported. And I'm sure there must be a way in which we can actually start gathering data of number of people waiting for long-term care through secondary and how they're being supported within the community at the same time. Thanks.
Happy to work on it. I think there are some challenges in some of the data collection, and I think using just managed practice data as a proxy brings into it some challenges too. But we will roll our sleeves up to that challenge. Yeah.
John Cunliffe.
Thanks, Mark. I just wanted to add to that in terms of, we've talked about wanting primary care measures in here for quite a while, and I'm aware that there have been some ongoing discussions about what we include. But I think also that the nature of this report historically has been driven by what Welsh governments wanted as a report. And in the past, we've had things like, as a proxy measure, the number of registrations with My Health Online, but that's then been dropped over time. And we've not had clarity from Welsh government in terms of what they expect for primary care measures. But it is a gap. We know it's a gap, and I think that's something I've had recent conversations on in terms of how we move forward, because we need something that is useful to us to understand the position around primary care, not just picking any data we can get hold of because it's we potentially can measure it. It needs to actually add value to our understanding, doesn't it?
It does, and Chris, you'll know too, this has been spoken about for many months now. We have got to somehow resolve this because we don't have visibility on primary care in the way that we should. And I know the difficulties around information and so on and so forth, but it is a gap that we have got to resolve and soon. I think too, I would invite the exec team to consider, particularly in terms of the notion of board to ward or board to primary care, a means by which we can get a sense as a board as to which practices are under particular pressure, because we saw that type of reporting for a different reason during COVID wave 1. But I do think we need greater visibility on the pressure or the escalation status, for want of a description, in terms of the primary care practices, because at the moment we're relying on anecdote or correspondence to tell us that there is a certain practice in the centre that's under significant pressure, or there's one in the east. And I think we need a more concrete view of where the pressure is being felt, Chris. So I think there's probably a qualitative aspect to this reporting as well that we need to consider.
So I'd certainly welcome that. I'll work with Sue and we will put forward a proposed section on primary care for you for the next one.
It would help, Chris, just on the back of that, if the area teams were reporting to you, and perhaps they are, but reporting to you and then on to board where those pressures are being felt, because they should know that themselves, and we should not necessarily have to find out from stakeholders on occasion. So I do think we've got to sort of improve the reporting line.
Yeah, okay.
Thanks. Lynn.
Thank you, Mark. On page 7 in the executive summary, there's a comment that suggests that we should no longer need to provide an exception report on mortality. Are we being asked to make that decision today? Because I feel that this does need a lot more thought about the process, because it is really a good red flag for us always to have.
Is there an answer?
Would it be helpful if I came in there, Chair? So Lynn, I think you make a valid point. I think there are probably 3 sources of mortality type data that we need to consider. Firstly is the output from our mortality reviews, and we are probably leading Wales in terms of the quality of those, but work to do to embed the learning from those. There's the ONS data, which sits a little more in the public health arena, but we need to be bringing that into that same story. And there are also mortality indicators within our CHKS data around the RAMI and other indicators that we perhaps can use more usefully. So I'm very happy to work with Sue to bring back a proposal, both for how we represent that on the dashboard, but perhaps just as importantly, how we bring that into QSE to give us a real clear understanding of what our mortality work is telling us. Would that be helpful?
Yeah, thank you.
Yeah, it would. That seems to be suggesting to the contrary, Nick, that we aren't going to stop reporting on mortality. We're actually going to improve the reporting thereof.
My personal feeling, Chair, is that the board should always have an understanding of what our mortality data is telling us. I'm not sure the historic way we've shown mortality has necessarily given us all the information we need to understand that story then.
Okay, thank you. John, before I come to you, Teresa, we lost you at the point at which you were responding to Cheryl around mental health. Can I invite you to carry on with your response, please?
Thank you. If you could help me, remind me of the question while I've been trying to work through IT challenges, that would be helpful so I can frame the answer correctly for you.
Cheryl?
Yeah, thanks, Teresa. I was just, it was more of a comment really than a question. I was just saying that you know, we're obviously all disappointed that mental health is not improving as maybe as fast as we were, but we're working so hard on the TI framework and making real measurable improvements are going to come from the changes we've made. It was more of a comment on that. Thank you.
Diolch, Cheryl. I'll have another go and kind of start from the beginning, Chairman, if I may then.
So, Teresa, so I think what would be helpful, because this question was asked by Public Accounts Committee yesterday, is to get a sense from you, Teresa, as to how assured you are that the actions now in train around mental health are likely to see or result in the improvements that you want to see, the board wants to see, and Public Accounts Committee was searching for yesterday. Yeah, thank you.
Thank you. So I do feel the right actions are being taken. So to be clear, I do feel that the TIF and the maturing matrix work gets us into the foundational space. We've needed to tackle those foundations, from my perspective, for some time. And that work is moving us forward. And I am seeing progress. And I joined the outcomes group, I think it was this week. And certainly I feel that we're on track in terms of evidencing the maturity matrix actions. But that won't be sufficient for us as a mental health division or as a health board, because we need to see changes. So we've also got those actions which are very much focused on today, and actions which relate to actual operational activities and changes, the way the reports, the way that we work with our teams, and that whole action planning. We've focused in on some specific deliverables now for the next 3 months, but we are doing so by working with our teams so that they are owned. That in itself is a cultural change. And I expect that is the third piece of the jigsaw. So the TI supports the foundational change. We've got the operational actions and our clear plans with teams working differently. But the third element will be that work on culture and OD, which is supporting us. We have many issues which are part of the team, part of the division, which we need to break the cycle of. I feel we're on that journey. That's an improvement journey. We're not there yet, but I'm grateful to colleagues on this call, to my executive colleagues and to Joe and everyone, the board support, because the team are reaching out for that support, and with the support coming back, I do feel we're moving into a different space. So I'm not sure, Chairman, from my perspective, I think we're on track. We've got some clear actions now, but we have to embed the change, and that is something I'm very keen on going forward. Otherwise, we will just relearn our mistakes. It's about learning continuously. We're involved in training, and for me, it is embedding going forward. So I'm grateful to Cheryl for her support. In terms of the performance data, we've been in a better place. It's disappointing to see the dip again just now, but again, we are working through that collectively and with colleagues across the health board. So hopefully we can get to a better place. I also do think we will need to get into that prevention and early intervention arena, because we are seeing people too late in the day. So maybe I'll end there, Chairman. Hopefully that answers your question and supports Cheryl's comments.
It does, thanks, Teresa. So final comment from John, and then I'm going to move us on.
Thanks, Mark. It was just a quick reaction and note of concern around the mortality piece that Nick referred to, just in that we have discussed mortality rates extensively in the past before Nick was with us. And I think we need to be clear about the difference between the raw mortality rate and something like the RAMI, if I'm understanding it correctly, because one's not really reflective of where we are, whereas RAMI is adjusted either by population or service, I think. But we just need to be careful, I think, in terms of what report, that it's truly reflective of what we're delivering and doesn't give a false impression.
Nick, you're nodding.
I am, and I'm happy if it helps John to go through some of the stats around some of the mortality information and get your view as to what you would find quite helpful, because it's a science in its own. It's a huge science, and I would appreciate your views.
Thanks, Nick. Thanks, Joe. Okay, I'm going to move us on then. That has put us behind our timeline, but that was an important conversation and a range of actions that we've agreed, given the current concerns about performance. So I'm going to move us now on to the finance report. Sue, can we assume, Sue, as ever, this is read, and can you focus on any highlights that you want to make? I'm conscious of the fact there is a report and there is also a presentation, but we are now pushed for time.
Yeah, thank you, Chair. I think the only thing I would highlight is that this is the draft unaudited financial performance of the Health Board as at the end of January, and we are currently reporting a balanced position in line with the plan for both in-month, year-to-date and the full-year forecast position. The forecast total impact of COVID-19 is currently 111 million, which is based on the assumption that that is fully funded by Welsh Government, so has no impact on our position. And I think the only other thing I'd highlight would be around the strategic support. So we've got strategic support of 42 million for the year, plus the 40 million for the deficit cover, and we've got 19.9 million for COVID-19 recovery. The impact of all that additional income is forecast into the position, and the only thing that I would say is that where we've had a delay in programmes within that strategic support because of COVID-19 impact this year, they have been forecasting to the rest of the year. And sometimes it is different schemes from those that we anticipated, but we've just made sure that we are optimising the use of that money. And I'm happy to take any questions on the paper.
Thanks, Sue. John.
Thanks, Mark. Thanks, Sue. Really, obviously, we saw this at PFIG, so I asked most of my scrutiny questions at that point. But it's just since we saw your reports at PFIG, has your view in terms of the risks from external factors like energy and those cost pressures changed significantly at all?
Yeah, thank you, John. Not for this year. I think we're all watching the energy prices really carefully, given the situation in Europe. But at the moment, there is no additional risk to the plan other than that we had discussed at PFIG.
All right, thank you.
Thanks, Sue. So we are asked to note the report, which has received scrutiny, of course, at PFIG, as John has just mentioned. And in that note, the draft unaudited financial performance of the Health Board through to January month 10, 2022. Are we happy to do that?
Yes.
Yes.
Thank you. Right, so we move on to the operational plan monitoring progress report. Sue.
Thank you. So this is the Q3 position for the Health Board. The report has previously been presented to PPPH in February and to PFIG. Page 5 includes a helpful summary of performance against the plan, both in total and across the 6 domains that we talk about, and it also includes a legend on that colour rating. There are now 50 reds in total, 19 of those are new in this quarter. 4 reds are in the enabling section, and the new red relates to delays in workforce optimisation programme, mainly due to COVID resourcing problems. There are 16 reds in planned care. 1 of those is new, and it relates to the Accurix procurement, which we thought was going to be funded by All Wales, and it isn't at the moment, so we're just looking at that plan. There are 5 reds against unscheduled care, but none of those are new for this report. And there are 10 reds in population health, 7 of those are new, and they relate to the smoke-free policy, smoking cessation, because that has been stalled by COVID-19 and different working patterns. Infant feeding strategy, where we have had a couple of recruitment issues, and the obesity service, which has the same issue, but we expect that to be caught up during Q4. There are 15 reds in mental health, 10 of those are new, and they are predominantly due to staffing issues. So it's just that sort of overall picture. And I'm happy to take any questions on the detail of the paper.
Okay, I'll open it up. John first.
Thanks, Sue. You just touched on Accurix, and it just crossed my mind in terms of Welsh Government have backed away from funding that on a national basis. And I think that's partly Accurix is linked to EMIS, if my recollection's correctly. Does that mean are Welsh Government funding an alternative linked to the other primary care systems that are used predominantly in South Wales, or have they backed away from any sort of national based funding?
Yeah, I'm sorry, John, I don't know the answer to that question, but Chris might know.
Yeah, John, you get to the root of why this is red. Is that we're having ongoing conversations with Welsh Government about the appropriateness with Digital Wales with regards to the appropriateness of us having Accurix funded in the same way as alternative systems are recognising the fact that we're using EMIS. So that conversation is still ongoing.
Right. So will you give us an update at some point, either through the board or through one of the committees?
Yeah.
Okay, thanks, Chris.
Thanks, both. Any other observations or questions from colleagues? No, well, I've got a couple, Sue. So we go to the report itself. First of all, there's reference in the covering report, Sue, to the accountability reviews carrying on, albeit they will change with the implementation of the new operating model. If they are, certainly at one point, a short note of the accountability reviews was being reported to PFIC. Does that continue?
It has done when there has been a meeting, but a couple of those accountability reviews have been cancelled during the Omicron variant. So that will be picked up again when we have the next meeting.
Right, okay. So can you pick that up with John in that committee meeting then for me, please? There is a section which I identified to you before, which is in red, that has no set of responses to it. And that is 4.5, which is particularly around specialist cancer therapy. And you'll see that there are 5 out of the 6 actions that are red and have been red for some time. I know Jill is not here, but I would like the board to receive an update or description of what the issues are in that area and what actions are being taken.
Yeah, Mark, I think Gareth is waiting to come in on this.
Oh, I think, okay, all right, Gareth.
Yeah, thank you, Chair. I can offer some commentary on that now, if that's appropriate.
It is, yeah, please.
Yeah, thank you. Yes, you will have noted that the majority of the actions there are clearly off target. They are all linked to the core action contained within this, which is in the first column, which is the production of a business case, specifically around specialist AHP resource in dietetics and speech and language therapy for cancer services. There's been a delay in the production of that business case, predominantly during the middle of the year, which is why the last report you had on this with September data also showed the same position. That delay was largely down to 2 factors. One was the absence of a critical member of staff involved in the production of the business case, but also because the team took the opportunity to participate in a more contemporary benchmarking exercise around staffing, which underpins the case for change within the business case. So that's largely why the delay is there. I can report the business case is now complete. It's been written. It's currently with the operational teams and is starting its journey of due governance to be brought forward.
Okay, so we'll wait to see that progress then, Gareth, and if necessary, it'll come to board, no doubt. Yeah. Okay.
That's correct. Sorry, Joe.
Thank you. So my next question is for Sue G. Sue, page 7, which relates to the action concerned with implementing year 2 of the Health and Safety Improvement Plan. the update provides some specifics around some inspection works that HC have undertaken and some of the issues that have arisen. But I couldn't work out from that update where you think we now stand in terms of implementation of year 2 of the Health and Safety Improvement Plan, and whether you feel it is progressing in the manner it should.
Thanks, Mark. So the reference was to the HSE inspection that was undertaken in November that we've been reporting through to QSE. I think you'll have seen that the rating around the health and safety action is slightly improved. I think we're more confident around delivery of year 2. That being said, it's a realigned year 2. We're also very confident of being able to go into the next financial year with a very clear set of priorities that will get us back on track. Clearly, the team has been working heavily on COVID safety related issues, as well as the HSE improvement notices and notices of contravention, but confident that we're getting back on track. The decisions that have been taken by the Health Board in terms of investing both resourcing, but also more importantly, the real focus on health and safety has been very, very helpful in helping us to move forward.
Thanks, Sue. While you're there, can I take us to page 9 then, which relates to 3.6 workforce optimization program, and you refer in the update to the independent recruitment process review, which was concluded on the 31st of December, and then go on to talk about a change plan and subsequently referred to workforce KPI and targets are in place. My question is, first of all, what is your plan in terms of sharing the product of that review and propose actions to respond to it? And also those workforce KPIs and targets that you're referring to, are they being reported onto board, or is that the plan, and when can we expect them, please?
Okay, thanks, Mark. So my plan around the recruitment improvement review, and I think I mentioned earlier, we're on the 4th cycle of improvement, so very much using that improvement methodology. My plan was to report that through to PPPH as part of the first workforce report that will be submitted following the beginning of the new plans and the new people strategy. We agreed with the chair that there'll be 2 workforce reports per year, with any interim reports required by the committee. So my plan was to do that. That report is due to go to PPPH, I think, in back end of April, May time, which will be the first reporting cycle against the strategy.
Thanks. So can I ask you confirm that with Linda outside, Sue?
Yeah.
In terms of PH, please.
Yes.
Okay. Then my next area is on the same page. Not for you, Sue, I don't think, but if some of it might be. Safe, clean care was identified as being a priority for the plan this year with actions. It refers to divisions to identify business case, which presumably there hasn't been, because it goes on to say no formal business case. A paper went to execs, etc. And then it goes on to say there's no formal strategy that's been drafted. A draft PID is to be written or has been written, and so on and so forth. So it doesn't give much by way of assurance in terms of what action is being taken, when we can expect to see those actions derive improvement in this area. So I was left thinking, Joe or whomsoever, I'm not assured by that update on progress, but then I didn't see any paper that went to the execs. So can someone respond to that, please?
Yes, I can. I'll make sure that we've got a little more detail to provide the assurance. One of the issues we've been discussing is the extent to which the principles and the work associated with safe, clean care become one of our transformation and improvement priorities for the year going forward. We have done an awful lot of work on safe, clean care during this current financial year, as board members will all be aware. The focus around safety and care going forward is around the ongoing maintenance agenda. So let's do some work just outside to confirm the extent to which we are able to continue the safe, clean care work as part of our improvement methodologies. Thank you.
Okay, thank you. So well then, if colleagues are happy, do what we've been asked to do and note the report and the actions have been recorded, or they will be. So I'll move us on then to the two substantive items that remain in the public session, because I feel that we ought to conclude the public meeting and then break for lunch now. So with your indulgence, we'll go to the regional population needs assessment. Teresa.
Thank you, Chairman. This is a regional piece of work and not a solely Betsy Cadwallader piece of work. And I would like to record at the beginning my thanks to partners for all their involvement and leadership alongside colleagues on this work. Some colleagues around this table will remember the first of the population needs assessments that was probably put in place about 5 years ago. So this is our second iteration of what is a very important document. Needs assessments are key in that they help us to plan based on the needs of our population. This work links to the Social Services and Wellbeing Act and gives us information about some of our most vulnerable groups and those that really do require some special work in partnership across the region. And so today before you, we have the second iteration of the population needs assessment. And I say that very carefully because, of course, we have wellbeing assessments in Wales as well. To me, they all dovetail together to give us the picture of need across North Wales. So I bring the paper to you today from a health board perspective. My sincere thanks to Wendy Hewson in the planning team and to Professor Rob Anstadt in the public health team. But as I say, this work has gone through the RPB. We've had leadership from colleagues right across the patch. Much of the work has happened locally, and then we've tried to take that regional view to make sure that we have those key messages which support some of the RPB discussions, will support the various organisations' discussions, but equally will dovetail with the wellbeing assessment information. So in front of you today is the document as it stands, being checked and worked through in terms of its accuracy. I would like to say that the contents were dictated by Welsh Government information in terms of their requirements. I do feel it's a comprehensive document. I bring it here as the document for approval. It is also going through all other organisations' governance mechanisms to ensure their approval. Although I would like to say the needs assessment should not be a on-the-shelf document. These documents really should be live. We need to use them. If they sit on a shelf, we have failed, I think, in terms of our planning work. And they are really the start of any planning discussion. So I bring them today for discussion in terms of content, but the content really has been locked down by the experts in their fields, and that's happened right across the region. I ask for your approval today in terms of being able to tell the RPB and our colleagues that we have seen the document, we agree with the document, and then we will take that forward. So I won't say any more, as I appreciate time is short today. So maybe if I stop there.
Yeah, Teresa, any questions or observations? John.
Sorry, I missed the button. Thanks, Mark. I think I raised a similar comment 5 years ago in terms of, I'm not sure a 250-page document with its additional documents with it is appropriate to come to a board if there isn't an exec summary for it. I don't think we can easily reach a conclusion of what's in there if it's not summarised. And you're asking us to approve it in terms of its content, notwithstanding the quality of the content that's there. I just feel very uncomfortable about the size of the document and what's expected of us when the conclusions that might be in it have not been summarised for us to really understand.
Thank you, John. If I may respond, Chair.
Please do, Teresa.
Thank you, John. I understand, and I think we can work on those executive summaries. I think some of that needs to come through when we have the wellbeing assessments, John, because this is one lens on the population. We also need to bring in the wellbeing lens. I think as they come together, and that will happen during this year and next, because 2023 is a key date for the wellbeing assessments. Again, potentially we can bring that together so that it's maybe more user-friendly, not only for ourselves, but also for partners. But I would have to say that really some of the detail has to be in this key document, because that is for planning purposes. But I take on board what you say, and maybe the opportunity for us going forward is, and I think there is a real commitment to understanding needs in North Wales. Maybe we try and think about how we harness the two pieces as they dovetail, as we should, and maybe we try and simplify that and bring it forward. I think the other offer for me would be how to bring this document to life for you, John, and for our partners. Maybe I would offer I'm not sure, a board workshop on the content, so that we bring those key statistics that are meaningful and make a difference forward, John, because I do appreciate what you say, but I do think that the detail is there for a reason, and that's for that planning element of our work. But I think going forward, we can bring that forward. And speaking as DPH, I do feel that as the IMTP now gets us into a better battle rhythm, the key bit of any planning cycle is understanding needs. Therefore, you can plan, and therefore you can commission or plan your activities. So I can work on that, John, in the background, and I would offer a board workshop if that would be helpful at this time.
Just to come back on that, Teresa, as I said, that I accept that the detail needs to be there from a planning point of view. That would be an operational activity, I would have thought. I think from a strategic point of view as a board, it just feels it's the wrong level of detail for us as a board environment. Others may disagree, but I just felt that this was too much detail for us to be able to understand the broad brush under conclusions that were there in the document.
Thanks, John. Okay, I'll come to Linda, then I'll come back on that. Linda.
Wel, hwrach bod hi'n braf cael gwahanol barn ar unrhyw bwrdd, ynde. A gai diolch i Teresa am dod â hwn o blaen y bwrdd. Dwi'n derbyn yn llwyr pwynt John hwyrach bod hi ddim mor hawdd â hynny i ni fel bwrdd deall yr uchelbwyntiau, ond gai croesawu'r dogfen yn fawr iawn. Dwi yn meddwl fel bwrdd iechyd, enwedig yn y cyd-destun cynllunio sydd o'i flaen ni, bod hwn yn hollol allweddol i'r tîm sydd yn arwain. Yn personol, dwi wedi darllen y cyfan a wedi deall lot gwell hwyrach y cyd-destun da ni fel bwrdd iechyd yn cydweithio. Ac hwyrach rhywbeth sy'n bwysig hefyd, y cyd-destun mae partneriaid ni hefyd yn cydweithio. Achos weithiau, pryd da ni'n trafod y bwrdd iechyd, mae o'n anodd iawn hefyd i gweld be di'r rhwystrau sydd hefyd yna ar ran ein prif partneriaid ni. A dwi yn gweld bod adroddiad cynhwysfawr fel hyn hwyrach yn sicr helpu fi deall hwnna well. Felly, yn personol, dwi'n croesawu o'n fawr iawn yn ei gyfanrwydd, ond dwi yn derbyn pwynt John ar ran trafodaeth mewn bwrdd. Bu fydda hyn hefyd yn defnyddiol os bysa'r tîm yn gallu paratoi uchelbwyntiau i'r bwrdd ei ystyried. Diolch, Teresa.
So just in that regard, Teresa, and acknowledging the observations that have been made, first of all, can I thank you on behalf of the board for overseeing such a comprehensive piece of work. The covering report refers to, doesn't it, the need to carry out a market stability report, which importantly will require consideration by local authorities and the health board of sufficiency of care and support provided, and particularly in response to the needs assessment. And it says that will be prepared and published in 2022. I think picking up on John's point, one, it would be helpful to see that as a board, Teresa, when it is ready. When we see it, it'd be helpful to see some sort of executive summary in that report or in addition to Tracer, so that we are able to take on board what it describes. There are some other deadlines set out in here, Tracer, which seem to be no doubt in keeping with guidance, but a long way away, in the sense of wellbeing plans have to be published 12 months after the wellbeing assessments have been signed off by the PSBs. And then it goes on to say that we'll be required to sign off the draft wellbeing plans, but that will take place in 2023. So my question is, so given those timelines and recognising there is a MSR to be produced as well, amongst all of this, are there any immediate actions or concerns that you or the executive feel that the board should be alive to and aware of?
Thank you. That's a very fair question, I have to say. So the timelines are rather confusing, because in the last iteration 5 years ago, they came together, but we are following guidance. So I'd say that immediately in terms of process. In terms of the key issues, the truth is that we need to address population health and to ensure that we give the right focus to those key vulnerable groups. So I think from my perspective, and if you read all the chapters, and thinking ahead to the wellbeing assessments, because I don't have that information at hand to share with you at this time, for me, it's the inequalities. The inequalities, as we all know through COVID, have grown. And for many of those cohorts of the public who are listed in this document, we need to ensure that we are providing support which is seamless for them as best as we can. So that's why I see it as a key document for the RPB, because many of the discussions relate to the Social Services and Wellbeing Act are there, but also to us as a health board. So I don't think there's any red flags that I need to call out today, but I would ask the planning team here and to work with the leads of our health communities, and for us as a health board to consider the vulnerable groups going forward, and to consider the inequalities that are in place now and sadly have grown during a COVID pandemic.
So, thanks, Tracer. Yeah. So my other question then goes on the back of that. Can we receive assurance from you and from Chris that sufficient consideration is being given then to the issues that arise from this needs assessment in terms of the priorities set out in the IMTP and the actions that go along with those priorities, and particularly in this arena? Because we ought to, oughtn't we, as you say, be clear about the implications of this assessment. We ought to be planning to respond to the concerns and inequalities that this might highlight, and the best vehicle to do that through is the plan. So are you and Chris happy the plan will enable us to do that?
So if I start, I do feel it puts us in a good place. Going forward, we are probably clearer on our planning cycle as a health board. I think as a regional partnership board, we are very clear on the priorities of work that needs to happen. We are solely one partner at that table, but I think the fact that we do come together in partnership to discuss key issues and have updates on our autism services, etc., shows that there's a commitment to the work in place. For me, I think we need to make that planning cycle clear for all our managers and clinicians so that they can see how they can highlight key issues going forward. I know Chris is on that in his IMTP wish for the future and having that clear business cycle, but I am so very used to be able to talk about the needs, to have that discursive discussion with clinicians about what's needed and with partners, because it's not just the medical world for an IMTP, it's all the health board business. So I am confident, but maybe at that point I have to stop and turn to Chris.
100% agree with everything that Teresa's just said. Planning has got to be built upon a population needs assessment. There's no point doing anything any differently to that, and I've been clear about that with my gang, and as Teresa says, we're reviewing the whole continual planning cycle to absolutely drive that one home.
Okay. Thanks. So, as the board driver of the needs assessment. Yes.
Yes.
Thank you.
Yes.
Right, thanks very much. Okay, thanks, Teresa. Right, while you're still there, let's move on to Welsh language, shall we?
Diolch yn fawr iawn, Cadeirydd, yna i droi i'r Gymraeg os gai. Mae'n ddrwg yna, dwi'n cael trafferthion technegol heddiw. Ond diolch yn fawr iawn i chi am gallu dod papur hwn yn ôl yma i'r bwrdd. Mae hwn yn dod yma ar ôl y cyfarfod y mis Gorffennaf 2021. Ac oedden ni'n trafod pryd hynny symud ymlaen hefo'r cydymffurfiaeth a safon 37. Wrth gwrs, fyddwch chi'n cofio hwn o ran y papurau bwrdd. Mae safon 37 yn gofyn i sefydliadau fel nina lunio dogfennau yn y Gymraeg drwy ystyried a yw'r pwnc yn ddogfen yn awgrymu y dylid ei lunio'n Gymraeg ac os yw'r gynulleidfa yn awgrymu y dylid llunio'r ddogfen yn Gymraeg. Wedyn mae'n bwysig iawn cysidro heina ar ddechrau'r sgwrs. Ers y trafodaethau nôl yng Ngorffennaf a wedyn eto y mis Tachwedd athon ni nôl pryd hynny, da ni wedi bod wrthi yn cyfieithu eitemau sefydlog ar yr agenda standing items a da ni yn ogystal wedi parhau i gyfieithu yr agenda, y cofnodion a'r cyflwyniadau. Felly dwi'n teimlo bod ni wedi symud ymlaen yn barod, ond wrth gwrs da ni bod yn trafod yda ni yn cydymffurfio hefo'r safon a dyna mae papur ni o'n blaena ni heddiw. Wedyn, y cam nathon ni gytuno a gofynwyd ohono ni oedd i gymryd asesiad a cynnal yr asesiad na yn unol â gofynion safon 37 i bennu pa bapura fyddai wedi bod angen i llunio'n Gymraeg dros y 6 mis. Wedyn, da ni wedi bod wrthi yn neud y gwaith yna a mae'r papur o'ch blaen chi heddiw. Mi welwch chi fod yna cwestiynau o fewn yr asesiad. Mae heina wedi delio o arweiniad gan swyddfa'r Comisiynydd. Felly nhw sydd wedi pennu mewn gwirionedd pa feysydd ydyn ni angen i archwilio'n arbennig wrth i ni benderfynu pa bapura fyddwn ni a sydd i angen i cynnyrchu'n ddwyieithog wrth i ni symud ymlaen. Felly mi welwch chi'r asesiad yn y gwaith papur. Y prif pethau da ni wedi sbio arnyn nhw ydy a yw'r pwnc yn ddogfen yn berthnasol i ni fel fawr o unigolion. A yw pwnc y ddogfen yn ymdrin â materion sy'n ymwneud â'r Gymraeg? A yw'r ddogfen yn rhan a fydd yn mynd ac cael ei arddangos yn gyhoeddus? A yw'n hysbys bod canran neu nifer uchel o gynulleidfa ar agwelir yn siarad Cymraeg a bod yn Gymraeg yn ystyried bwysig iddynt, neu a ydynt yn gweithredu drwy'r Gymraeg? A fynodd mwy nag un unigolyn i'r ddogfen fod ar gael yn y Gymraeg? A yw'r ddogfen yn debygol o ddenu ymateb a sylw'r cyhoedd? Ac yn ola, a yw'r ddogfen yn un y mae'n yfonol i unigolion ymateb iddi? Felly, fedra i ddeud bod ni wedi cynnal yr asesiad, mi welwch chi'r niferoedd ar gwaith papur o fanna. Da ni wedi edrych ar papura cyfarfodydd mis Medi, mis Tachwedd a mis Ionawr, a dwi'n ddiolchgar i swyddfa ysgrifennydd y bwrdd am ei cymorth i wneud y gwaith yma. O ran y canlyniad yr ymerfer hwn, y math o bapura a fyddai wedi bod angen i cyfieithu ydy'r straeon y cleifion, wrth gwrs da ni'n gwybod bod hynna'n bwysig tu hwnt, diweddariadau Covid, diweddariad byw'n iach, aros yn iach, y gwasanaethau wroleg, cynllun gwydnwch y geia, diweddariad fasgwlaidd. Wedyn mae yna criw pecyn o bapura fysa ni'n gallu edrych arnyn nhw yn Gymraeg. Ond mae yna ddau brif beth a da ni wedi trafod hein yn y gorffennol. Da ni angen i hystyried wrth symud ymlaen. Mae yna effaith ar y cyllid oherwydd mae'r gwaith sydd yn digwydd yn y cefndir yn costio ar ddiwedd y dydd, fedra i'n cuddio hynny. Ac hefyd o ran amserlen cyflwyno papura, a da ni'n gwybod sy'n mor dyn mae y system cynllunio'r papurau bwrdd yn gallu bod. Dwi'n rhan o hynny a weithiau dwi'n ar y lein, dwi'n dydy ddim yn hawdd. Mae rhaid i mi ddweud mae'r tîm cyfieithu yn barod yn gweithio tu allan i capacity. Da ni wedi selio'r ffigurau hyn ar anfon gwaith allan o'r bwrdd iechyd oherwydd da ni yn derbyn fwy a fwy o cyfieithu nag erioed. Peth da ydi hynny, ond mae o yn her. Felly mi werwch chi'n y papur y gwaith o ran yr cyllid, mae hwnna o fewn yna. O ran yr amserlen, dwi'n gwybod fod swyddfa ysgrifennydd y bwrdd yn codi pryder am yr amserlen fod pethau yn dyn ac yn poeni na fyddwn ni'n gallu cael y papurau allan yn ddigonol o ran yr amserlen. Felly, be da ni angen mewn ffordd heddiw yma, a mae'n ddrwg gynnau am ddeud chydig bach mwy nag arfer ydy, trafodaeth ac ystyriaeth o ran y camau nesaf a sut fyswn ni fel bwrdd eisiau symud ymlaen. Felly os gai jyst mwyn crynhoi y prif ystyriaethau ni ydy, Mae rhaid ni gofio'r amserlen ar gyfer cyflwyno papur ar bwrdd, a da chi gyd yn gwybod sut mae'r dyn mae hynna'n mynd. Byddai'n parhau fod yn ofynnol cyflwyno'r papura i'r swyddfa. Da ni'n eisiau newid hynny, da ni'n deall yr anghenion o ran audit a disgwyliadau ar bwrdd iechyd. Fyswn ni eisiau ddeitha chi fod yna diffyg capacity o fewn y tîm, a da ni yn gorfod gweithio hefo asiantaethau allanol, a dwi'n meddwl bod nhw wedi cael braw ar faint o ddogfennau sydd angen i gyfieithu hyn ar hyn o bryd. Mae yna gostau i'w gofio o ran costa allanol, ac wrth gwrs mae yna potensial i ffeithio'n andwyol ar allu'r sefydliad i ddarparu gwybodaeth amserol a chyfoes i'r bwrdd. Mae hynna'n bwysig fod pobl yn cael y gwybodaeth yn yr iaith sy'n hawsau nhw i ddeall. Felly mi welwch chi yn y papur 3 opsiwn i benderfynu a oes awydd i ni gymryd y cam pellach hwn o ran y cydymffurfiaeth hefo safon 37. Mae opsiwn 1 yn glir, parhau gyda'r broses gyfredol o gyfieithu agenda, cyfnodion, cyflwyniad ac eitema sefydlog. Opsiwn 2, cymhwyso'r asesiad i holl papur ar bwrdd a allai dileu'r angen am gyfieithu eitema sefydlog. Neu opsiwn 3, rhoi'r broses asesu ar waith dros 3 chyfarfod nisaf y bwrdd gydag adolygiad o'r hyn y gellir ei gyflawni a gweld yn hir dymor ymhen 6 mis os ddyllen ni symud ymlaen. A dyna di'r 3 opsiwn. Wedyn, dwi'n ymddihiro i aelodau'r bwrdd bod fi wedi trafod pethau chydig bach yn fwy manwl heddiw, ond dwi yn teimlo fod ni'n cyrraedd pwynt da ni angen gwneud penderfyniadau. Diolch yn fawr iawn, Cadeirydd.
Before Linda comes in, and it's not often I do this, I'm strongly of the view that we need to do more, and I favour option 3. I don't, in some senses, much care what other health boards are doing. They're already lagging behind us. I think we need to demonstrate our intent in terms of the Welsh language as a board, and we are seeking to do that as individuals and a group, and I think it's really important. Linda.
Wel, mae'n braf iawn gallu cytuno gyda'r cadeirydd, felly dwi'n falch iawn o hynny. Gai ddiolch i Teresa a'r tîm am paratoi'r adroddiad mae cynhwysfawr yma. Dwi'n cytuno i'r carn efo'r cadeirydd. Mae o'n bwysig iawn i ni fel bwrdd iechyd bod ni'n ymrwymo i gwasanaethu ein holl gynulleidfa, ac yn y gorffennol mae wedi bod yn anodd iawn i derbyn papur allweddol mewn iaith dewisol. Dwi'n teimlo bod opsiwn 3 yn rhoi hyblygrwydd i ni fel bwrdd i asesu be fydd y waith ychwanegol ar ran y cyfieithu a sut fydd bobl yn ymateb i'r ffaith. Fel person sydd yn defnyddio'r papurau Cymraeg sydd ar gael, be sy'n anodd i fi ar hyn o bryd ydy symud o Gymraeg i Saesneg oherwydd mae rhai papurau cwrs ddim ar gael yn y Gymraeg. Ond dwi'n meddwl mi bydda arbrofi fel hyn dros y 6 mis nesaf yn rhoi cyfle i ni fel bwrdd i asesu yr effaith ac yr effaith hefyd ar ran sylwadau gynharach yn y cyfarfod o gallu paratoi papurau mewn pryd. Mae hwnna'n amlwg yn mynd i fod yn her. Ond gai cytuno gyda'r cadeirydd, dwi'n ffafrio opsiwn 3 hefyd.
Iawn. Any other observations? Are there any dissenters from option 3? No? Okay. So are we happy to support option 3?
Dwi'n ddiolchgar iawn, Cadeirydd. Nawn ni roi cynnig arni a ddown ni ar papurau nôl fel da ni wedi sôn ym mhen amser wrth i ni wneud adolygiad. Diolch yn fawr iawn i chi am y penderfyniad dewr heddiw.
Okay, diolch yn fawr. So we will move on then, if I may. We're moving into the close of the business. Items to refer to committees, I think that we've picked that up where necessary, but feel free to disagree in terms of the discussions we've had so far. Louise, I don't know if there are any risks that you feel we've highlighted within this meeting that we need to review, or whether anybody else feels the need to do that. Louise?
Thank you, Chair. My sense would be the risks that we've discussed today are either on the corporate risk register or will be shown at an appropriate level on the BAF, which is obviously going to be reset following the workshop on the 7th of April. So, and I think there's lots of work going on around risk at this moment. So I think if we don't feel that, then there's obviously an opportunity to feed into that process following this meeting.
Thank you. Are others happy with that?
Yes.
Okay.
Yes.
Review of meeting effectiveness. Can I invite any colleagues who've got some observations around the effectiveness of the meeting to let those observations go to Louise and Molly, and then they can consider. Assuming you agree with that, I'll now move us on to the summary of private business. It is shown there. Louise, is there anything you want to say about that item?
Thank you, Chair. The only comment I would make was that obviously we had a quality update in the private session last time, and the subsequent update will be coming into the public meeting, as you've mentioned earlier, on the 30th. So it's just to close that loop. Thank you.
Thanks, Louise. Okay, so date of the next meeting is the 26th of May. I hereby now exclude the press and the public as we move into private session.